consultant of adult medical oncology, and he's the director of MENA NCCN Coordinate Center. So we will be having an honor to have faculty from regional area, from international and regional areas, and we are glad to have them all, and we'd like to thank them for accepting our invitation and their continuous support to our meeting. Today we're going to have two sessions. The first session will start soon, and then we'll have another session. We'll be having 4 satellite symposium today. We'll finish inshallah at 6:30, and dinner will be at 7 o'clock. Tomorrow we'll start at 8:30, and we'll finish inshallah at 5:30. So there will be a parallel session for breast cancer survivors, and this session will be in Arabic. I would like to thank our staff at King Abdulaziz Medical City, who worked very hard for this session, and they prepared everything, starting from the agenda of the meeting and their talk and calling the patient for that session. I would like to thank the attendees. We will be, just to let you know that we do have around 14,000 patients registered for this meeting. I would like to thank them all and encourage them to participate actively in the meeting by sending their questions. Of course, this meeting is supported by a generous support from the companies, drug companies like Novartis, Gilead, Lilly, Pfizer, AstraZeneca, MSD, and Roche and Al-Hikma. Would like to thank them and for their generous support and continuous and sustained support to our meetings. Again, thank you so much, and I wish you a very successful and engaging meeting. And without further ado, I'm gonna give the mic to my friend and colleague, Dr. El-Gerni, to start the first session. Dr. El-Gerni, please.
Assalamu alaikum. Thank you very much, Dr. Nafisa, for the kind introduction. And it's my pleasure to chair the first session with a dear friend and colleague, Dr. Sharif Al-Simani. Dr. Sharif is a well-known medical oncologist at King Abdullah Medical City in Mecca. And Dr. Sharif, please start to introduce our first speaker. Thank you.
Okay. Thank you very much, Dr. Al-Qarni, and I would like to thank Dr. Nafisa as well, and all the team who organized this meeting on annual basis. And it's my pleasure to open the first session with to chair it with my dear colleague, Dr. Mohammed Al-Qarni. So we'll have a session that will talk about breast cancer in young patients, and we'll have very interesting talks in this session. We have 4 talks and 4 eminent speakers in this session. We'll start with the first talk with Dr. Anne Partridge. She is very well known in the field of medical oncology. She's the the Department of Medical Oncology at Dana-Farber Cancer Institute, and she's as well the Director of Adult Survivorship and co-founder and Director of breast cancer. So Dr. Partridge will talk about the role of ovarian function suppression in young patients with breast cancer, and the role as well of molecular tools, especially breast cancer index, in predicting the response of ovarian function suppression. Please, Dr. Partridge, the mic is yours.
Hang on one second. I'm sorry, I didn't go back to the beginning. Let me get back there. Thank you so much for inviting me to share with you today. Let me get to screen share again. And I'm delighted to be with you. I'm sorry it's not in person to speak about the role of ovarian function suppression in young women with breast cancer. We all know this is an area fraught with excitement because there's a lot of interesting new data over the last several years, as well as challenges with our patients because it can be a challenging treatment, particularly for our very young patients. And we're going to talk about the role of the breast cancer index, in particular risk prediction markers, to help us to decide who might need this and might not need this. But let's just set the stage. So, breast cancer subtypes by age clearly have different distribution. This is true in the US, as you can see depicted here. And I believe it's also true in Saudi Arabia and around the world from what I know about the disease demographics. The majority of young women have ER positive disease, though, even though the proportions go down as women go down in age. And when they have ER positive disease, when you're younger, you're more likely to have a luminal B than a luminal A tumor, as has been shown in the Carolina breast cancer study and other studies subsequently. We all know that young women are more likely than older women in screened populations in particular to present with more advanced anatomic stage. And all of those things combined put them at higher risk of recurrence and death, despite typically getting chemotherapy. And so we're looking for more and more ways to improve their outcomes, including optimizing their hormonal therapies. And they often lag behind postmenopausal women in terms of the advances for lots of reasons that we could get into in the question and answer. But we ultimately did learn that both for postmenopausal women and then finally for premenopausal women in the late 90s, that tamoxifen adds substantial value. You can see here the latest update from the Oxford overview that tamoxifen in women with or without chemotherapy who are premenopausal adds a substantial benefit, as much, if not more, as it does in postmenopausal women. Again, this took a long time. For anybody who is younger, you may not realize that for years we did not give tamoxifen in our older patients. Despite the clear benefits, in our younger patients, despite the clear benefits in our older patients. But you can see the difference. We've also known for over 100 years the value of ovarian ablation. And here you have it compared to chemotherapy in older studies, where it appears to have a similar risk reduction for all comers in premenopausal women to chemotherapy, about a 30% risk in recurrence and a mortality benefit that was similar in these old studies when compared to nothing. And we know that that's about the benefit we get from chemotherapy for all comers in the overview. In older studies, when they were compared and added, there was no benefit when ovarian suppression was added to chemotherapy, presumably because for many of those premenopausal women, the benefits of chemotherapy were due to the ovarian function suppression. And then historically, we had no data that was robust on addition of ovarian suppression to tamoxifen in premenopausal women in the adjuvant setting until the text and soft designs came along. You can see the graphic here, and we all know it was initially presented in 2014, and then it's been updated over the last several years, giving everyone endocrine therapy in text and soft. In text, everybody got ovarian function suppression, and then they were randomized to get tamoxifen or exemestane and aromatase inhibitor as the partner. And in soft, there was an arm that was tamoxifen alone to test the question of the addition of ovarian function suppression. And as you can see here, the 8-year follow-up results, which I think show this very nicely, are when the curves really started to separate, particularly in the people who got chemotherapy, with very clear differences in disease-free survival rates for the groups that got ovarian function suppression. You can see here that there were also differences in distant recurrence as well as overall survival that became very, very clear at that time, with the ovarian function suppression adding tremendously, and then the exemestane adding, especially in disease-free distant recurrence, not so much addition in terms of overall survival. That took longer, as you would expect. We've subsequently had the ASTRA trial where tamoxifen was only given for 2 to 3 years, and that compared to tamoxifen alone, ovarian function suppression, and that addition also added similar benefits in terms of risk reduction, even when done for a shorter time. And the HOBO trial has also shown us additional benefits from ovarian function suppression or the use of an aromatase inhibitor in the setting of ER-positive disease in premenopausal women. So more and more data telling us we should be thinking about this. And so how do I incorporate ovarian function suppression? Currently, I think when we think about premenopausal women, for higher risk patients, certainly likely based on both anatomic stage and biological risk, high grade, a genomic expression predictor, high risk, ovarian function suppression. Anybody I gave chemotherapy to, I want to give them an aromatase inhibitor with OFS as tolerated. For moderate risk patients, higher anatomic stage, smaller tumors, but higher grade, higher genomic expression, those patients, I will think about tamoxifen or an AI plus OFS, and it might even be reasonable to sequence these as it was done in Big 198 and the TEAM trials, but we don't have good data in premenopausal women. Although when we look at these kinds of things in premenopausal women, usually long after they've been studied in postmenopausal women, we do appear to get similar benefits and similar results historically. For the large group of lower risk patients, so low grade, not big tumor, premenopausal, not that young, didn't need chemotherapy, low anatomic and low genomic risk, if I'm sending that, then tamoxifen alone still remains quite adequate, because even with a 24% risk reduction, which is what it amounts to, for many people, that's going to be quite modest and not worth the side effects of the ovarian function suppression without a clear survival advantage in those lower risk patients. But what about in the second 5 years? What do we do for those patients where you want to give more than 5 years of therapy? Because we increasingly want to do this. Well, why do we want to do this? Because we know that women with ER-positive disease continue to have recurrences, especially after 5 years, whereas in the ER-negative setting, they seem to plateau out after 5 years. Here are data for premenopausal women from the Oxford overview for continued recurrences, and this is, of course, using tamoxifen. You can see that in the ATLAS trial, which was a very nice study of 10 versus 5 years of endocrine therapy, tamoxifen, that it did add a substantial and significant improvement of about 4% in terms of recurrence and nearly 3% in terms of breast cancer mortality for continuing tamoxifen for 10 years. And there were premenopausal women in this, about 20%. In the ADAM trial, we saw strikingly similar results. This has not been published yet, but there have been other work done on this study, but similar 3% advantage in terms of breast cancer death by the allocation of 10 years to 5 years of tamoxifen after an initial 5 years. Now, we all know that this has been studied across the board, predominantly in postmenopausal women. So you've got the ATLAS and ADAM trials at the top, but now we've had MA17, but now we have multiple additional studies that have extended endocrine therapy, including AI in the first part of the 5 years or in the second part of the 5 years. And the bulk of the data suggests benefit from extended endocrine therapy. And when it's been tested, 10 versus 7 years, because do we really need a full 10 years, or could you do 7 to 7.5 years? Fortunately, we have a suite of studies that now suggest that for the majority of patients, 7 or so years might be good enough. So most of us land on 7 years for someone that you want extended endocrine therapy for in the postmenopausal setting, because that's where we have reasonable data that it's good enough. In the premenopausal setting, I would argue the only data we have for the second 5 years is ATLAS and ADAM, where it was tamoxifen for 10 years. So that's kind of what we're stuck with. Katie Ruddy, one of my colleagues at Mayo Clinic in Rochester, Minnesota, is working on a trial with the Alliance Cooperative Group, where we want to look at what to do in the second 5 years for women where we want to optimize their endocrine therapy. This is called the EOS trial, or Extended Ovarian Suppression Study. And the goal is to determine whether an additional 5 years of OF and AI or TAM reduces late recurrence compared to an additional 5 years of TAM alone in these patients. So we would use the ATLAS and ADAM results as our control arm in the second 5 years, or at least to actually model and predict the numbers. And we want to take high risk women. We don't want people that aren't likely to have an event. And so that has led us to, like, how do we predict those high risk women? And more importantly, how do we predict who we should expose to a second 5 years of ovarian function suppression? Because especially for the very young women, those women, if you put them into permanent menopause, which that essentially might be when the average age of young women is still 37 when they're diagnosed, if you do 40 and under, and if you do 50 and under for premenopausal, you end up, it's about 46 in terms of the average age. You're essentially condemning them. And I hate to say it like that, but you're, doing 10 years of no estrogen, and that has long-term and late effects potentially. So it better be worth it from a breast cancer risk reduction standpoint for both the tolerance and the long-term health risks. Well, there are lots of work going into how we can determine who needs treatment in the second 5 years. Again, much of this has been done in postmenopausal women, and you can see the comparison of prognostic assays that was published by Jack Sestak or Ivana Sestak years ago now, showing how well predictive these prognostic measures are in node negative and node positive patients. And you can see that the kind of old-fashioned recurrence score, which we often use to predict benefit of chemotherapy, is not as helpful in the second 5 years. And compared especially to some of the newer scores that incorporate not just a genetic prediction assay, but also the new genes as well, or different genes, as well as clinical variables, as you can see here. And I was asked to talk about BCI, and I'll focus on that because that's where we have some new and exciting data in premenopausal women. So BCI, or breast cancer index, is both prognostic and predictive for benefits, for risk and for benefits of endocrine therapy in the second 5 years. It's based on 11 genes and 2 signatures, as you can see described here. The BCI predictive, we hope it helps us to predict who's likely to benefit, and prognostic of who's, individual's risk of who's likely to recur over the 10 years, particularly in the second 5 years. You can see the genes that make up the 2 different scores. And in the N1 group, the score is also incorporating T size and grade, because that adds prognostic value. And there's separate algorithms. And this assay has been used to predict late recurrence in TransAttack and an MGH cohort, as you can see here. It was pretty good at separating out the highs from the lows. Intermediate was very close to the lows. For late distant recurrence, only BCI and TransAttack remain prognostic beyond standard clinical pathologic factors, and only the HI ratio added prognostic information. So it's pretty interesting. It's a complicated assay, I think, but really seems to add some value here. When it's been looked at in the TEAM trial, you can see it also was good separating out for distant recurrence and late distant recurrence at beyond 5 years. And, as you'll recall, TEAM trial was exemestane versus tamoxifen, switching to exemestane for 5 years. And you'll note that 53% of node negative patients had BCI intermediate to high, and 77% of node positive. So it wasn't just about anatomy. The BCI was prognostic significantly for overall distant recurrence and late distant recurrence in both node negative and node positive patients, as well as in HER2 negative patients. And it remained significantly prognostic after adjusting for age, tumor size, grade, and treatment. So pretty compelling. This has been looked at in multiple other data sets now with some mixed results, MA17, TransAtom, IDEAL, and I think the least impressive was B42, where there was less of a skew and concern that that it was underpowered due to the modest distant recurrence benefit in the parent trial. And the benefit was more apparent in the HER2 negative subset. But clearly it's quite prognostic and predictive in most of these studies. So what about in our premenopausal women? So the BCI analysis cohort derived from SOFT is only a fraction of the patients. It's 1,600 patients or so. And the goal in the initial presentation from San Antonio just this year was to evaluate if BCI is prognostic in node negative and node positive N1 disease, and to evaluate whether or not high status was predictive of ovarian function suppression benefit. You can see the updated final results from SOFT, or not final, but most updated, that after 12 years of follow-up, there's a 3% improvement overall in 12-year freedom from distant recurrence with the use of exemestane and OFS, so the most aggressive endocrine therapy. It hasn't changed that much over the last couple of years. That's all comers, and the bulk of that is in the higher risk patients. You can see here in terms of predicting late recurrence, 39% of the node negative patients were BCI intermediate or high, and 78% of the node positive patients were BCI high. BCI was prognostic for overall distant recurrence in both node negative and node positive patients, and the BCI N1 risk groups and tumor grade were highly correlated. So, one thing you think about is grade a surrogate for this to some degree? But you can see here BCI did add. Of note, 58% of cancers were BCI high, BCI low, and 42% were BCI high. This was contrary to their study hypothesis. BCI low was predictive of the benefits of endocrine therapy, OFS, but not BCI high. So the higher risk patients didn't get a clear benefit from ovarian function suppression. A similar pattern was seen regardless of subgroup. So this is where it got a little tricky. So it was prognostic, but weirdly not predictive of benefit in the way we thought it would be. You can see that here. There have been lots of thoughts about how and why this may be. Getting into the genetic changes of the BCI genes, and then in premenopausal women, untreated women, low ratios could predict for estrogen responsive disease, and that might be it. The BCI high HI has been validated to predict tumors that benefit from an extended endocrine therapy historically due to endocrine responsiveness and late recurrence. But those patients with low tumors may have higher risk of early recurrence, resulting in greater benefit from augmented ET endocrine therapy in the first 5 years for these tumors. And the high tumors may have higher risk in later years. So the choice in earlier years 1 to 5, could have less impact. So I don't think we understand why we're seeing what we're seeing, but there's lots of thinking about, like, what does it mean about the pattern of recurrence in these patients? And are we removing some of the risk of the higher risk patients, and or are they less endocrine responsive and then not getting the benefit of those higher risk patients? So, ASCO has done a lot of thinking about this, and NCCN in our guidelines in the United States, and currently Breast Cancer Index is something that is okay to do if a patient has node negative or node positive breast cancer. It's mostly been tested in 1 to 3 positive nodes, has gotten 5 years of endocrine therapy without recurrence, and it may help to guide decisions about extended endocrine therapy in that group. Then, with a evidence quality intermediate, strength of recommendation moderate. And I think in the setting of premenopausal women, I think it's really hard to know how it should guide us. Should we use the lower risk group to give the extended endocrine therapy for? That kind of flies in the face. And then, is this really going to help us if we have high risk people, particularly if they still have breasts? Because we know that extended endocrine therapy with tamoxifen may increase the benefits in terms of second primary. That was shown in the Atlas and Adam trials. So, do we need to add ovarian function suppression? I don't think we know. And there are many strengths and weaknesses to BCI. Right now it's the only genomic assay that has been validated to benefit from extended endocrine therapy. It outperforms Oncotype DX, which is the one we use often. It's currently available. It is recommended to consider by ASCO NCCN, not necessarily aggressively in premenopausal women in light of these data. It may spare the low-risk women on the HI score for potential toxicities of extended endocrine therapy in the postmenopausal setting, but it could increase patient compliance with extended endocrine therapy, and I'll show you those data. And it could change physician recommendations, but there are a number of weaknesses, which include, that the validation studies are small. There's conflicting results with B42, and it was predictive in soft, but it was predictive in ways that we didn't expect it. There are only limited data for higher risk patients, for premenopausal patients, and they're awkward for HER2 positive patients. There are lingering questions about the added value beyond clinical pathologic factors, including grade. It doesn't really provide us any guidance around the 7 versus 10 years, who might benefit from that. Again, it's not clear that it predicts value from upfront OS when you're making that decision. And in the US, at least, it's not cheap. And I would imagine over there, it's not cheap. There was a study that was done that looked at how it might impact on decisions. And I think it's pretty interesting that we know that women are less than adequately compliant with their extended endocrine therapy. That shouldn't surprise us because they're non-compliant or non-adherent to their early endocrine therapy. And we understand that it's tough to tolerate this. And getting a score and using this decision to impact on their score to impact on their treatment decisions. 30% of physicians' extended endocrine treatment recommendations changed after a BCI result was brought. So 71% of people said not to do it when they were going to do it because we were just doing it based on endocrine, endocrine sensitivity and the usual anatomic stage and maybe a prior genomic predictor. And 29% went from not recommend to recommend. So it may indeed spare patients. And among those patients who were recommended, 82% of them said that after the BCI results, they would be more likely to be adherent with treatment based on the BCI results. So when people get a number that says, yeah, you're high risk, they are more likely, and it feels less squirrely, they're more likely to stick to the regimen and worry about it. So in conclusion, premenopausal women with ER positive early breast cancer continue to have risk of recurrence after 5 years. We all know that, and we want to do something about it. Extended endocrine therapy benefits them overall. The benefits are clear, though modest, 4% and 2% survival, at least with tamoxifen. Could we do better with ovarian function suppression in select patients in the second 5 years? We don't have any data for that yet. Hopefully we will in the coming decades, although it takes a long time to study these things in our very young patients. And finally, I think efforts to understand who will benefit and which therapy is worth it are underway, including further studies using assays like the BCI and the study I told you about, the EOS trial, which will be a study that I think we're going to have to do throughout the world, like SOFT and TEX were done, as these may help us to tailor care better for individual young patients. Thank you.
Thank you very much, Dr. Patridge. Very interesting talk. Actually, and I guess it will elicit a lot of questions at that discussion, but we'll keep questions till then. So, Dr. Karni, if you can introduce the next speaker, please.
Thank you very much, Prof. Patridge, for this nice talk. Now we'll move to the second presentation. And it's my pleasure to introduce a dear colleague, Dr. Ahmed Al-Shehri, who is a senior GI and breast oncologist at King Abdulaziz Medical City in Jeddah. He's going to talk to us about the role of adjuvant therapy for high-risk hormone receptor positive breast cancer. Please, Dr. Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Muhammad, for the nice introduction. I would like to thank my colleagues also for their kind invitation to talk about this important subject. I'm really sorry about the quality of voice that I have because I'm just trying to catch a flight, which unfortunately came to a conflicting time with this talk. But I'll try my best, inshallah, to be in a nice and quiet place in a few minutes, inshallah. Let me share my slides. Do you see my slides, Muhammad?
Yes.
Yeah, thank you so much. Right, I was asked to talk about the adjuvant therapy in high-risk hormone receptor positive, HER2 negative early breast cancer. This subject actually includes several aspects, including the use or the role of adjuvant chemotherapy in what we call high-risk hormone receptor positive patients, namely using the recurrence genomic scoring system, and the most widely used in our country and in our oncology centers are the Oncotype DX, which has a prognostic and predictive value at the same time. We know that the higher the score, the poor prognosis, the higher the score, the more benefit of chemotherapy will be anticipated in such kind of breast cancer subtype. Most of us are aware of the TAILORx study, where those patients have been categorized into three different risk categories, from 0 to 10, from 11 to 25, and above 25. Those in the middle group, the 11-25, they have been randomized to receive either adjuvant endocrine therapy alone or endocrine therapy plus chemotherapy. Basically, there was no difference between the two groups with regard to the primary endpoint, which is invasive disease-free survival, and other endpoints, including overall survival. So chemotherapy did not add that much to adjuvant endocrine therapy in those patients in the intermediate risk category group. However, if we look into those patients who are 50 years or less, we can see that there are some benefit that can be driven from those who having a score of 16 and above, like from 16-25, there might be some benefit of using adjuvant chemotherapy. So chemotherapy benefit might be discussed with the pros and cons, with the side effects and everything to those patients. And if they agree with that and they agree with the magnitude of benefit that can be provided, they can get this kind of chemotherapy. So this will summarize the TAILORx study in node negative hormone receptor positive breast cancers. If we have an age of 50 and more, we can use the cutoff limit of 26. So if the patient has a score 26 and above, chemotherapy is indicated. For those who are less than 50, we can use the cutoff point of 16. So 16-25 to 25, we can offer chemotherapy. However, if it is more than 26, chemotherapy benefit might be a little bit big. So the chemotherapy is indicated in those patients. What about node positive patients? We have the RxPonder study, which again, they included those patients who have up to 3 lymph nodes positive, and they have a recurrence score of 20-25 or less. The patient can be randomized to receive endocrine therapy alone or chemotherapy followed by standard endocrine therapy. And this did include premenopausal and postmenopausal patients. If we include the intention to treat population, all patients, there might be a small benefit of chemotherapy that has decreased the invasive disease-free survival. However, if we classify those patients into premenopausal and postmenopausal, we can see that postmenopausal patients, they derive no benefit of adjuvant chemotherapy if they have 1 to 3 lymph nodes and recurrence score less than 25, while premenopausal, they still derive significant benefit when it comes to invasive disease-free survival and overall survival. There have been a lot of argument. Was it the chemotherapy benefit itself, or was it the ovarian suppression effect of chemotherapy that has caused this benefit in premenopausal patients, i.e., can we use the ovarian suppression as a substitute to chemotherapy in these patients to gain the same kind of benefit that was shown in this study or not? So we don't know the exact answer here. However, based on this study, the premenopausal patients with 1 to 3 lymph node positive, even with a low recurrence score of less than 25, might be offered chemotherapy if they agree with the benefit and possible side effects. And this slide will summarize how to use the Oncotype DX in node-negative and node-positive patients. The addition of ovarian suppression to AI in premenopausal patients, and also switching from tamoxifen to exemestane in premenopausal patients have been well covered by Dr. Partridge. So I wouldn't go in details with the study. All of us are aware of the SOFT trial comparing tamoxifen versus tamoxifen plus ovarian suppression. And we know that addition of ovarian suppression did improve the disease-free survival. And there was also a benefit in overall survival, specifically in those patients who had received prior chemotherapy. And who are those patients who receive prior chemotherapy? Are those who are younger in age, who have larger tumor size, and who have positive lymph nodes. And also we had the combined analysis of SOFT and TEX trial using exemestane plus ovarian suppression instead of tamoxifen plus ovarian suppression. And we can see that exemestane plus ovarian suppression was better than tamoxifen plus ovarian suppression with regard to disease-free survival. However, there was no significant difference in overall survival. So again, who are the group of patients who derive most of the benefit of such kind of combination? Are those younger patients with larger tumor and lymph nodes positive, specifically those patients who receive prior chemotherapy. And again, as we heard from Dr. Partridge, that the breast cancer index might play a role here to decide with regard to those patients who might get most of the benefit of having the addition of ovarian suppression or switching to exemestane instead of tamoxifen. What about extending endocrine therapy to beyond 5 years? As again, Dr. Partridge talked about the ATLAS and ATOM trial, and we have seen that extending tamoxifen to 10 years as opposed to 5 years of tamoxifen has reduced the risk of disease recurrence significantly, as you can see in this slide with a hazard ratio 0.75 and in both trials, the ATOM and ATLAS trial. So we have to keep in mind when we extend the endocrine therapy approach that we have to look at the long-term side effects, impairment of quality of life, and adherence issues and fertility issues with regard to those patients. So all of these like factors has to be taken in consideration when we consider extending endocrine therapy to beyond 10 years. So there are several factors that can help us to choose whether 5 years or 10 years, clinical pathological factors, genomic testing, specifically breast cancer index, which was well covered by Dr. Partridge in her nice talk in the past half an hour. MA17 is another study talking about extending 5 years of letrozole after 5 years of tamoxifen, and there was an overall survival benefit specifically for those who have lymph node positive patients. We'll come to the most updated data with regard to high-risk hormone receptor positive patients using adjuvant olaparib. All of us have heard about the Olympia study, which included those patients who have triple-negative cancer and hormone receptor positive HER2-negative cancer. What is more important to us is the hormone receptor positive HER2-negative breast cancer subgroup, and they included those patients who had prior neoadjuvant chemotherapy who did not achieve PCR, and they have a clinical pathological staging with estrogen receptor and grade score of 3 and more, and also included those patients who had upfront surgery and they had 4 positive lymph nodes and more. So those patients, they have been randomized to receive the olaparib versus placebo. Of course, if hormone receptor positive, they should receive the standard adjuvant endocrine therapy. It has to be highlighted here that hormone receptor positive patients, they constitute less than 20% of those patients included in the Olympia study. So as you can see, the primary endpoint was met. There was significant improvement in invasive disease-free survival in favor of olaparib for the intention to treat population, including hormone receptor positive and triple negative patients. The same for distant disease-free survival. And most importantly, overall survival also, there was a significant benefit of, like in favor of using 1 year of olaparib as adjuvant treatment in high-risk patients. Of course, this kind of benefit of olaparib will be with the expense and cost of the toxicity, including nausea, fatigability, and bone marrow suppression like anemia and neutropenia. And also the financial toxicity is another concern using this agent in the adjuvant setting. And this kind of agent was approved for all those patients who are classified to be a high-risk hormone receptor positive or triple negative if they have germline BRCA mutation. And this kind of approval was done almost a year ago. Once again, if you consider that in hormone receptor positive patients, you have to look if the patient presented for adjuvant treatment post upfront surgery, those who have 4 positive lymph nodes and more are considered high risk, and this kind of treatment can be considered. Those patients who are post-new adjuvant treatment and they did not achieve PCR, they should have a clinical pathological score with ER and grade score of 3 and more. And this is what the clinical pathological score that I have been mentioned is a table well known that everybody should get reference to calculate this kind of score in those patients who did not achieve PCR post-new adjuvant treatment. So they will be a candidate for adjuvant olaparib if they have germline BRCA mutation. What about the other biological treatment, which is adjuvant abemaciclib? Once again, those patients have been randomized if they have been classified to be high-risk hormone receptor positive, HER2 negative patients. Who are those patients who are considered high risk? Either they have 4 or more positive lymph nodes, or those who have 1 to 3 lymph nodes plus either one of these, the following, either tumor size of 5 centimeter or more, histologic grade of 3, or Ki-67 of a score of 20 and more. You can see that the invasive disease-free survival, which is the primary endpoint of this study, was met. So there was a significant improvement by using abemaciclib 150 milligram twice a day for 2 years, plus standard endocrine therapy as opposed to standard endocrine therapy alone. And this was maintained over 2 years and 3 years. As you can see, at 3 years, there was an absolute benefit of almost 5% with regard to invasive disease-free survival in favor of abemaciclib arm. And when we talk about distant-free survival, we can see still there is a significant benefit in favor of abemaciclib. And this kind of benefit was shown regardless of Ki-67. So whether Ki-67 is below 20 or more than 20, the benefit of abemaciclib was maintained, and Ki-67 was more like prognostic factor rather than predictive factor in the study. However, overall survival benefit was not different by use of abemaciclib, at least until this study was reported. And this is true even for the high Ki-67 population. Again, there is some sort of safety concerns using abemaciclib in the adjuvant setting, including diarrhea, fatigability, arthralgia, and neutropenia, and of course, the thromboembolism that have been reported with abemaciclib. So again, you have to discuss the pros and cons of using this kind of treatment with the expected benefit with your patients before starting this treatment as adjuvant therapy. Once again, adjuvant abemaciclib have been approved by FDA. The FDA has mandated a Ki-67 more than 20, like a score more than 20 to be like a candidate for abemaciclib. However, the ASCO and NCCN, they included abemaciclib in high-risk hormone receptor positive population, regardless of the Ki-67 score. Future directions, there are several studies trying to address, again, hormone receptor positive high-risk population, including use of adjuvant everolimus. Again, there is also a study addressing the role of ribociclib in the adjuvant setting. There are 2 studies addressing the role of use of trastuzumab deruxtecan plus endocrine therapy in HER2 low breast cancer population. Of course, they are hormone receptor positive. And there is also another study using sacituzumab govitecan in the adjuvant setting in hormone receptor positive patients. Again, and last but not least, the use of oral SERDs like elacestrant. There is a study is being actually recruiting for the use of elacestrant in the adjuvant setting in high-risk hormone receptor positive population. So as a conclusion, when we talk about hormone receptor positive population, we have to think about the first part, which is chemotherapy, and we have to incorporate the genomic profiling. Most popular in our country is the Oncotype DX, and we have the recurrence score of 26 and more. They have to receive chemotherapy. If the recurrence score is less than 25, from 16 to 25, and age less than 50, you might consider chemotherapy for younger patients less than 50, but more than 50, probably they are safe without chemotherapy. For other agents, including abemaciclib and olaparib, we said that if the patient has 4 positive lymph nodes, this is a general indication for either one olaparib or abemaciclib, 1 year of olaparib or 2 years of abemaciclib. The preference of use of either agent has to be discussed with your patient, including the toxicity profile, the financial toxicity of either agents, and you have to look on the data that olaparib did include those patients who have the overall survival benefit. The olaparib study showed overall survival benefit. However, less than 20% of those patients were hormone receptor positive. Other than this, for abemaciclib, if patients have 1 to 3 lymph node positive, tumor size more than 5 centimeter, high grade, or they high grade, or they have KIC7 more than 20, the abemaciclib can be considered. So this will summarize all the treatment options that can be used in high-risk hormone receptor positive patients, from chemotherapy to extending endocrine therapy to use of ovarian suppression plus endocrine therapy in premenopausal patients, and use of biological treatments including olaparib and abemaciclib in high-risk group. And with that, I would like to thank you for your attention, and sorry for any kind of echo during my road trip here.
Thank you very much, Dr. Ahmed. It was very nice and clear. And we'll keep the question till the end. I would ask our attendees to post their question in the Q&A box if they have any question. And Dr. Sharif, now to present our next speaker, please.
Okay, thank you very much, Dr. Mohammed. Now, it's my great pleasure to introduce Dr. Khair Abou Khair. She is very well known in the field of medical oncology, and she had a lot of contribution to the field of medical oncology in Saudi Arabia and the Middle East. Dr. Khair is a consultant of medical oncology at Sulaiman Habib Hospital, and today she will talk about the advances in the management of early-stage triple-negative breast cancer. Please, Dr. Khair.
بسم الله الرحمن الرحيم والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Assalamu alaikum. Good afternoon, everybody. Thank you, Dr. Sharif, for this kind introduction. And I would like to thank Dr. Nafisa and Dr. Mohammed Al-Garni for inviting me to participate in the second breast cancer in a special situation forum. My talk is, we are shifting the gear to triple-negative breast cancer. So what I'm going to talk about is advances in the management of triple-negative early breast cancer. This is the agenda over the coming 20 minutes or so. I will try to cover this topic, or these points in particular. First of all, until now, in our daily practice, we are diagnosing triple-negative breast cancer based on immunohistochemistry, ER negative, PR negative, HER2 negative, 0 to 1, or 2+ with FISH negative. This subtype of tumor characterized by high grade as well as high Ki-67. Not only that, What's specific about triple-negative breast cancer? They have shorter survival rate as compared to non-triple negative, as well as they are more likely to have distant recurrence as compared to hormonal positive. In addition, the first early 3 years after diagnosis, the highest rate of recurrence among this group as compared to non-triple negative breast cancer. And they have certain relapse pattern. They are higher risk of early timing, as I mentioned, and special sites such as CNS as compared to hormonal positive. It's reported to be between 25 to 46 in triple negative breast cancer, and some visceral such as liver and lung. What we have learned over years on treatment of early triple negative breast cancer, we learned that achieving complete pathological response, it improves overall survival. So overall survival as a function of response to chemotherapy. As you can see, the yellow color, those with pathological complete response as compared to those with red color, with residual disease and non-responder. And based on that, there are several trials focused on improving pathological complete response by using different chemotherapy regimen, combination polychemotherapy, as well as dose intensification chemotherapy. And this table, pardon me, excuse me for this very crowded, but summarize all the majority of the dose-dense trials that comparing different treatment dose-dense regimen. And as a part of this, they published in the Lancet in 2009 and 2019 the meta-analysis of 26 clinical trials that included more than 37 women with early triple negative breast cancer used the dose-dense therapy. And the result of this, there is an improvement in breast cancer mortality and progression-free survival in those with the dose-dense therapy as compared to regular regimen. What else other than dose density? Can we add more chemotherapy differently, which will improve the pathological complete response? And here it comes the use of carboplatin. And why carboplatin in particular? We knew that a triple negative breast cancer, there is higher chance of harboring germline mutation, BRCA mutation. So this table summarized some of the trial that included the use of a platinum for early triple negative breast cancer, as well as bevacizumab, anti-angiogenesis, Avastin. And the result, as we can see, that there is significantly improving and higher BCR rate, 54 versus 41%. But unfortunately, neither carboplatin nor bevacizumab has been shown to improve recurrence-free survival or overall survival. However, that study was underpowered, so we cannot make any clear determination. Then, can we improve on BCR much more? And here it comes recently, the use of immunotherapy in breast cancer, especially that chemoimmunotherapy can target several steps in the immunity cycle. And in addition to that the first checkpoint inhibition in advanced triple negative breast cancer showed a modest response rate with monotherapy. So why not to use it a little bit early? And here it comes the famous trial that I know everybody in the room are aware of, which is the Keynote 522 presented by Prof. Peter Schmidt at ESMO 2019. And this trial was a positive trial. Just as a reminder, this is a phase 3 randomized trial, included patient with newly diagnosed triple negative breast cancer, locally advanced T1C to N1 or 2, or T2 to T4 in 0, with excellent performance status, and tissue were tested for PD-L1 as well, PD-L1 assessment. These patients were randomized to either the classical chemotherapy that we are using, which is carboplatin paclitaxel, then doxorubicin AC, EC or AC, plus pembro versus the same chemotherapy regimen plus placebo, then surgery, after surgery, a year of adjuvant pembro versus placebo. And there are stratification factors, nodal status, tumor size, carboplatin, whether a schedule, whether weekly or Q3 weekly. And the new adjuvant phase defined at the start from first new adjuvant treatment and ends after definitive surgery, while the adjuvant start from the first adjuvant treatment and include radiation therapy if included. And here's the result. Definitive PCR, it's reported, it's a positive trial, consistently showed that there is PCR 65% in the pembro arm as compared to 51% in the placebo arm. Not only that, but also this has been shown in both PD-L1 negative as well as PD-L1 0. And there is an improvement at first interim analysis, which was presented at San Antonio 2020, with improvement of event-free survival up to 91% as compared to 85% in the placebo arm. Based on that, FDA approved the use of pembro as a new adjuvant for locally advanced triple-negative breast cancer. Then a year later, after completion, long-term follow-up, almost over 3 years period, with the use of adjuvant chemotherapy for 1 year, there is an improvement of 1 year pembro associated with a 3-year event-free survival with a hazard ratio 0.63. It has been reported 84.6% in the pembro arm as compared to 78% in the placebo arm. The second trial that I would like to share with you is the EMPASSION 031, which is again a new adjuvant immunotherapy, but this time it is atezolizumab plus chemotherapy. And this is a smaller trial than Keynote 522, but included 333 patients with the same locally advanced breast cancer and known PD-L1 status, no prior therapy, and excellent performance status. And these patients were randomized to either atezo-nab-paclitaxel versus placebo plus nab-paclitaxel for 12 weeks, and then the anthracycline regimen, AC plus atezo versus placebo plus AC, then surgery, and then atezolizumab for 11 doses, the same thing for adjuvant for 1 year. Again, EMPASSION 031 showed that there is benefit of PCR, improving in PCR rate 57.6 as compared to 41.1 in the placebo arm. And this is in both PD-L1 negative and PD-L1 positive. So what we have learned, and these regimen very well tolerated and reasonable with, but we have to pay attention to some side effects, which is associated sometimes with immunotherapy, such as thyroid problem, hyper or hypo. The most common is hypothyroidism, in addition to other colitis, hepatitis, and others. And we have to pay attention to how to tackle these side effects in particular. The other trial, which is GBAR-NUOVO, and this trial, unfortunately, it is a smaller number of patients, included 174, but they used in this trial durvalumab, and this is a little bit different. They started with the durvalumab, and then they got biopsy, and then again chemotherapy plus the immunotherapy, and then repeat at the end of the session of therapies, biopsy, and then they continue with the anthracycline and then surgery. Unfortunately, there is no improvement in PCR among placebo versus immunotherapy arm, but consistently, as you can see in the diagram, that there is consistently higher invasive disease-free survival, distant disease-free survival, and overall survival with durvalumab. Again, what we can notice with longer outcome that PCR similar irrespective treatment with pembrolizumab. Also, I need to, I don't know if you can see in this arm were G-bar-Novo, that those with PCR or non-PCR, there is a split in the curve among those who received immunotherapy and placebo. Though the number is small, but all in favor of immunotherapy. What about adjuvant? We all knew the study that addressed the residual after neoadjuvant chemotherapy in triple-negative breast cancer, which is the addition of capecitabine. And with improvement of 13.7% disease-free survival benefit and 8.5% overall survival benefit with the use of capecitabine for almost 6 months after triple-negative neoadjuvant disease and residual disease. Again, just a reminder, I mentioned this earlier, the adjuvant 1 year of immunotherapy, again, it showed that there is a 3-year event-free survival, and there is almost 37% reduction in the risk of relapse with the use of 1 year Pembro. Now I will talk about one more study, which is Olympia A, presented by Dr. Ahmed Al-Shehri for the subtype, which is germline mutation, hormonal positive. And I will focus here on the germline mutation, BRCA mutation, triple-negative breast cancer, where they included patients and if they received a neoadjuvant and they have non-PCR, or after adjuvant with triple-negative high-risk features, such as tumor size more than 2, equal or 2, or T2, or heavy nodal involvement more than in 1. And those patients, usually after a treatment, they were randomized to either olaparib for 1 year versus placebo. And the baseline characteristic of these patients were well balanced among the 2 groups, placebo and olaparib. As you can see, they included hormonal positive as well as triple negative, all with the prior neoadjuvant or after adjuvant. And here's the efficacy. The primary endpoint, there is in the intent to treat population, there is an improvement in invasive disease-free survival and recurrence of death reduced by 42%. Invasive distant-free survival benefit associated with olaparib maintained with 1 year additional follow-up as well. And olaparib demonstrated a significant overall survival benefit with 90% of patients alive at 4 years in the olaparib arm. And over 7% more patients treated with adjuvant olaparib were free of distant recurrence or death at 3 years versus placebo. With longer follow-up, confirmed distant disease-free survival benefit of adjuvant olaparib, and they are free, 7% more patient free of distant recurrence. So we conclude from that patients with high-risk early triple-negative breast cancer, they have many options, and the new standard of care after neoadjuvant, we can continue with adjuvant Pembro, and those with the BRCA mutation, 1 year of adjuvant olaparib for, of course, eligible patient is well tolerated and improve clinical outcome. And both of these medications are included in the NCCN guideline with the dose-dense therapy, as well as the olaparib in case of germline mutation, as well as high-risk triple-negative preoperatively Pembro. It's included in the NCCN guideline, which is commonly used by all of us. With this, I conclude and thank you.
Thank you very much.
Thank you very much, Dr. Mulkhair. Thank you very much for the very interesting talk. We'll keep the discussion till the end. Dr. Qarni, if you can introduce the last speaker, please.
Thank you, Dr. Sharif. Now we'll move to the last presentation of this session by Dr. Mut'ab Al-Fadi, who unfortunately couldn't join us physically for emergency reasons. So he sent the recorded presentation about the advance in treatment option for triple-negative breast cancer.
Sure.
So, Assalamu alaikum. First of all, I would like to thank the organizer for their kind invitation. And I have been tasked over the next 20 minutes to discuss the new treatment options for advanced triple negative breast cancer. So I am going to review the development of immunotherapy for metastatic triple negative breast cancer, and to discuss the supporting data for the combination of the immune checkpoint inhibitor and the chemotherapy, as well as the biomarker for metastatic triple negative breast cancer. And I will end up with antibody drug conjugate in this setting. So this is just a snapshot a couple of years ago, looking at different subtype of breast cancer and a different setting at which the immunotherapy was being evaluated. So this is just to highlight that we're a couple of early area of emphasis. So first, obviously, in triple negative breast cancer, which is a subtype for which there was a few available effective therapy, or indeed no effective therapy beyond chemotherapy until quite recently. And the second emphasis, while most of this was obviously in the metastatic setting, where these immune strategies are typically evaluated, trials at adjuvant and neoadjuvant setting were conducted early on in the course of clinical trial with the checkpoint inhibitor in breast cancer. And as you can see that in the blue and red colors, the neoadjuvant and adjuvant studies are listed here and having started early, and those have read out, and now actually they are impacting our clinical practice. So recognizing that this trial have occurred in the context of a really evolving therapeutic landscape for triple negative breast cancer, we are 5 years ago. We had chemotherapy alone with no targeted therapy. And now in 2023, we have the PD-1 / PD-L1 immune checkpoint inhibitor, as well as the traditional chemotherapy. We have the PARP inhibitor, and also we have a new antibody drug conjugate, the TROP2, as well as the more recently HER2 and ADC that are relevant for triple negative breast cancer. Also, we are going to have in the next few years the AKT inhibitors. So let us review the pembrolizumab monotherapy in untreated metastatic triple negative breast cancer, and this is just as a historical snapshot. This is the phase 2 trial of pembrolizumab as monotherapy, where it was initially evaluated in triple negative breast cancer, the KEYNOTE-86 line cohort. And what we can see from this progression-free survival analysis and the subgroup analysis, first, that the vast majority of the patients with metastatic triple negative breast cancer donor respond to single agent immunotherapy. However, some do, and their overall response rate here was about 20%. And of those who do respond, durable responses are observed. So quite remarkable when it does work. So identifying the patient in whom it can work has been a challenge. Some clinical features shown on the right side, which are associated with greater or less benefit from the immune checkpoint inhibitor, but essentially these have not been expanded to a large extent and was not explored at the monotherapy trials. So as we know that the monotherapy trial have not advanced into clinical implication. So insights from PD-1, PD-L1 immunotherapy trials in the metastatic triple negative breast cancer, a minority patient can respond, and those responses are durable, and the PD-L1 immunohistochemistry of the therapy and some clinical features like presence of liver metastasis, high LDH are associated with response and no response, and the treatment was generally very well tolerated. The first lab study, which was the phase 3 trial of immunotherapy, was performed as monotherapy compared to chemotherapy in the second or the third line metastatic triple negative breast cancer, was the KEYNOTE-119. And this is actually a high bar. So we just saw that even in the first line setting, immune checkpoint inhibitor as monotherapy have infrequent activity. So comparing this monotherapy to chemotherapy in a later line setting where there is even less activity was a real challenging setting to evaluate monotherapy strategy. Ultimately, this study was a negative trial, so the immunotherapy with pembrolizumab was not superior to standard chemotherapy in the second or third line setting. And here, as you can see with the CPS1 and 10 cutoff showing, but it does again demonstrate that there are some patients in particular with CPS score more than 10 group, there appear to be some plateauing in these overall survival curves. And in an exploratory analysis, we saw that with higher levels of CPS score, for example, more than 20, and increasing plateau of patients who may drive durable benefit in a later line setting for triple negative breast cancer, where we know the prognosis of a typical patient is very poor. So this was sort of the end of pembrolizumab or the immune checkpoint inhibitor as monotherapy in the metastatic triple negative breast cancer. And the subsequent evaluation really turned to combination with chemotherapy, where the chemotherapy is the standard treatment for this disease, and the concept that chemotherapy may actually facilitate the induction of the immune response through its immunogenic property. So a pragmatic and possible some underlying science to support the combination with standard chemotherapy. So this is the first study which delivered results in the first line metastatic setting was the ENVISION 130. It combined the atezolizumab with nab-paclitaxel in a standard randomized design with a co-primary endpoint in the intent to treat population and in the PD-L1 positive population for both PFS and overall survival. And these are the BFS data. So there was a very small but statistically significant improvement in the intent to treat population and more clinically relevant in the PD-L1 positive population by using the immune cell 1% assay SD142. And with the additional follow-up, it was demonstrated that the overall survival in the PD-L1 positive group was numerically improved, as you can see, from 17 months to 25 months. So looking at the dark red versus the dark blue curve. So meaningful numeric improvement, but not one which could be called statistically significant because of the hierarchical design of that clinical trial. Nevertheless, this resulted in the first immunotherapy approved in breast cancer with this combination in the triple negative breast cancer subtype with an accelerated approval by the US FDA. So some other relevant insight here is the PD-L1 assay doesn't matter. So the SD142 IC1% positive in approximately 45% of the patient, substantially less than the 22C3 CBS1 cutoff. And when this combination was used, it was really important therefore to use the correct assay for that 45% of the patients who are positive, rather than to use the larger group who are positive by other assays. As you can see here, when these results were analyzed for the group who are CBS positive, such as the one in the middle band, but IC negative, there was actually no apparent benefit of the combination treatment. So unfortunately, a follow-up study, the IMpassion 131, which was similar in design, but used the solvent-based paclitaxel as opposed to nab-paclitaxel, was a negative trial in the IMpassion 131. So the overall survival was not improved in this clinical trial, and consequently, this resulted in the withdrawal of the accelerated approval for atezolizumab in US. So does the chemotherapy really matter? So the Keynote 355 used 3 different chemotherapy treatment options: nab-paclitaxel, or paclitaxel, or gemcitabine carboplatin in the first line metastatic triple negative breast cancer, with or without pembrolizumab. And patient had to have treatment-free interval of at least 6 months compared to the 12 months in the IMpassion study. And as you can see here, patients who were enrolled used the taxane in approximately 45%, carboplatin and gemcitabine in approximately 35%, and the CBS score more than 1 was initially the primary biomarker when the study was designed, but it was changed over the course of the trial before any results were available to the CBS score 10 on the basis of the Keynote 119 result, which we discussed earlier. So approximately 40% of the patients were positive at CBS score 10 level. These are the final results for the overall survival, 3 endpoints with the intent to treat population: CBS score more than or equal to 1, and CBS score more than 10. And it is the greater 10 population which was positive according to statistical design. So this is a positive study for overall survival for the CPS score more than 10 and led to approval of pembrolizumab in combination with chemotherapy in the first line setting for that population in US as well as other places around the world. And one of the important questions which was actually raised in the keynote 355, where you do see the separation in the CPS greater than one group. And what about those patients with the CPS score between 1 and 9? Is there really a benefit, or it is all driven by those with higher CPS score number? So this is an additional analysis looking at that, which illustrates that it is the higher group who derive from the benefit. So if you look at the CPS score between 1 to 9, there was actually no benefit with the addition of pembrolizumab in that population for the overall survival. What about treatment-related adverse events? So the combination of chemotherapy and immune checkpoint inhibitor pembrolizumab was very well tolerated. Most of the toxicity actually from this regimen are driven by the chemotherapy, where the side effects were frequent. In regard to the immune-related toxicity, they were uncommon with the exception of the thyroid dysfunction. There are actually lower frequency of more serious side effects. So some answer from this clinical trial. So the addition of immunotherapy to chemotherapy improved outcome for some patients. The PD-L1 expression is a clear determinant of that benefit, and the appropriate assay and cut off. And the appropriate assay and the cut off must be used based on the data that we have to guide the effective application of these clinical strategies. Long-term benefit may be achieved in some, and finally, the combination of chemotherapy and immunotherapy are generally tolerated with no anticipated combination toxicity. Question remain, however, what is the impact of chemotherapy backbone? Are there other ways to identify those who benefit? And certainly, there have been other correlative study of this trial and of the monotherapy trial as well, which suggest other benefits of high tumor-infiltrated lymphocyte and interferon gamma signature by the gene expression. And there may be other way to look at the kinetics of response, including, for example, the circulating tumor DNA kinetics that could identify early responder to monotherapy. And finally, there is actually a true synergy between chemotherapy and immunotherapy that is achieved, or rather, are we just getting more benefit because some patients respond to the chemotherapy and some patients respond to the immunotherapy, and by getting the two treatment, we get more benefit from the combination. In terms of the ongoing development and of the immunotherapy for metastatic triple-negative breast cancer and about the future. So for the population where the immunotherapy and chemotherapy is the established standard, that is the CPS score more than 10, the current investigation is actually focused on replacing chemotherapy with those new generation of antibody drug conjugates, which are highly effective as cytotoxic therapy in triple-negative breast cancer. That include the sacituzumab govitecan in the ASCENT trial and the datopotamab deruxtecan in TROPION trial. And as you can see, the waterfall plot of the combination of D2DXD and the durvalumab as first line in metastatic triple-negative breast cancer was associated with high response rate of approximately 75%. On the other hand, for patients with lower level of CPS score, where the immunotherapy is not a standard dose between 1 to 9 CPS score, there are actually different IO combinations that are being evaluated in those populations. So before ending, I will just show you the recent result from the antibody drug conjugate. So, for example, the ASCENT trial in the metastatic triple-negative breast cancer, where the sacituzumab govitecan was actually superior to the treatment of physician choice in both progression-free survival and overall survival, with the hazard ratio of 0.41 and 0.48 respectively. And now it's becoming a standard of care after first or second line metastatic triple-negative breast cancer. And also the trastuzumab deruxtecan in the DESTINY Breast 04, which actually included approximately 10 to 11% of patients who has hormone receptor negative, HER2 low, which we in the past call triple negative. And the result showed that the progression-free survival and the overall survival in those patients with hormone receptor negative, HER2 low, was similar to the hormone receptor positive population, with a significant improvement in both progression-free survival and overall survival. And with that, I would like to thank you for your kind attention.
Thank you for all the speakers. Now we have about 5 minutes for a few questions. I would ask Dr. Khair to come to the stage. Dr. Sharif, do you have any question?
Yeah, thank you very much, Dr. Muhammad. I couldn't see any question in the chat box. So if you don't mind, I would have a couple of questions, one to Dr. Patridge and one to Dr. Khair, if you allow me, Dr. Muhammad.
Yeah, go ahead.
Okay, so thank you very much for your presentation, both Patridge. It was very nice, actually. But as I said before, it elicited a lot of questions, actually. So my first question to you, do we have any data about the add-on prognostic value of molecular tools like BCI index, in addition to the clinical tools like CTS score? How much do we, the additive prognostic value in addition to the clinical scores? So we have data of their prognostic value that dissected by node positive versus negative. But in addition to these prognostic, the clinical prognostic factor, do we have data about their utility, especially the high cost of these tools? This is the first one. The next one, are we really ready to be used in routine practice, despite having the conflicting data of their predictive value from the MammaPrint? And you have seen the rate of MammaPrint, it's predictive only in patients with low risk. And you just mentioned as well the SOFT trial and only low risk that have some predictive value, but not in high risk, despite our expectation to have value in high risk. So can you comment on that, please? Thank you.
Sure. And I think the question is, how do we use this in our clinics, right? So the data, there are clear data that in some of the studies, it adds prognostic and predictive value to our usual anatomic risk markers, as well as when we consider some of the other genomic health markers, it's better, right? I showed a table of that where it does appear to be more predictive of both prognostic and predictive of endocrine therapy benefits in the late setting. That being said, it's highly correlated with things like grade, and will it really drive decisions, and is it worth it? Or are we going to give it anyway for many patients and will it, will we give it anyway? And the decisions to stay on therapy are often based on things that aren't necessarily about risk. They're often about how people feel about the drug, the value of the risk reduction, and their tolerance, and other logistical reasons. And so how much will it influence? I think for some people it will and does influence. And that's what you saw in that study of, were people going to be more compliant if they knew that they had a higher risk and that this predicted maybe getting more benefit. I think for some segment of people we care for, it could be considered for that reason alone. I will tell you that we've discussed this within our group at Dana-Farber, and for select patients where we think it will influence our decisions, then we do send it. But it's not a standard at this point because the data are also mixed, as you alluded to. And some of my slides showed it's not perfect. We're not sure what to do in the premenopausal patients, which was what I focused on, because it's sending us kind of mixed signals. What are we going to give it to the people with lower risk disease otherwise? We might, if they have it high, but we might also give it to the people with higher risk anatomic disease. So it's really not going to help us that much. You're going to give it to everybody if they tolerate it who has enough risk. And so I think we're a little bit kind of, selectively using it until we have better data that it's going to help people more and it helps, and that it's worth it from a cost standpoint. I don't know what you guys are doing, but that's kind of how we're doing it.
Great. So before going to Dr. Mulkhair, just to in brief, Prof. Patridge, to make it clear to our audience, can you give us your algorithm for selecting patients for extending adjuvant hormonal therapy, and what are the group of patient, cohort of patients that you will go to ask for PCI or other molecular tools for decision making? Can you please, in short statements,
Sure.
T1, T2, would you give? Would you ask T3, not negative, not positive? So please.
Yeah. So anybody with T2, T3, N1 disease, I offer it because we know that anatomic risk alone is a high risk factor. I definitely offer it and I talk to people about it. For lower risk node negative small tumors, it's really about how they feel about it, whether they have high grade tumors, because we know that increases the risk, or any other concerning feature. And we talk about it and how they tolerate it. I think I've sent 2 BCI scores so far, to be honest. And my threshold for that, honestly, is the patient asking for it, or the patient really being on the fence and kind of struggling with their decision. And therefore I'll say, well, we could get this test and it may or may not be helpful.
Yeah.
That's kind of what I'm doing.
Great. Thank you very much. Dr. Karni, do you have a question for Dr. Mulkhair, or shall I proceed with one question?
No, proceed, Dr. Sharif.
Okay. Dr. Mulkhair, thank you very much for your interesting presentation. So you presented the data of the role of immune therapy in the early stage triple negative breast cancer. But as you mentioned, we have data from the Pembro study, but in the Guibar-Novo study, despite lacking any adjuvant, any immunotherapy in the adjuvant part, and despite there is no statistical difference in terms of PCR, but we have clear difference in disease-free survival. So can we conclude from that we have the benefit in terms of disease-free survival depends on the carryover effect of or the late effects or late beneficial effects of immune therapy, and this may question the role of the adjuvant part of immune therapy in the Pembro study. So do you think that all what we need is a Pembro in addition to neoadjuvant chemotherapy, and the adjuvant part we may omit for selected group of patients, or what's your approach?
Definitely, for triple negative breast cancer, especially locally advanced nodal positive, I would recommend definitely the use of, and this is what I do in my clinic, I use Pembro or immunotherapy plus chemo. The adjuvant, it depends. Until now, there is a benefit. 1 year, there is risk of recurrence, but the overall survival, we are still waiting. Dedicated data is still ongoing. We don't have the result yet for it, for overall survival. But for certain patients who doesn't achieve a pathological complete response, I will give adjuvant Pembro as well.
Can I add a comment? We're actually studying this in a large trial called the Optimized PCR in the US, where we're studying in people who have a PCR,
Yeah,
whether
please,
they
please,
need
please
the
go ahead.
adjuvant, whether they need it.
Yes, until we get the final result from, there are other two trials addressing this question of adjuvant Bembro. So until the results available, for the time being, this is what I do in the clinic. I use it in the new adjuvant. Those who achieved PCR, I don't continue. The one who did not achieve PCR, I continue with adjuvant Bembro.
So just one question, Dr. Khair, in continuation of this. So for patients with BRCA-related breast cancer who receive immunotherapy in the neoadjuvant setting, and they meet the criteria for adjuvant olaparib, what would you use in the adjuvant setting?
I'll use adjuvant olaparib.
Okay. So I think, Dr. Sharif, this is the end of this session. I would like to thank all our eminent speakers for this informative and nice discussion. And we'll have a break for about 15 minutes. We'll be back at 4 p.m. to continue our sessions. Thank you very much.
Thank you very much, Dr. Muhammad. See you soon, inshallah. Thank you very much.
السلام عليكم. الحضور الأعزاء، يشرفنا حضوركم معنا في هذا المؤتمر اليوم. نود لفت نظركم إلى أن الساعات سيتم منحها لجميع الأشخاص الذين يقومون بحضور المؤتمر كاملا، والمتكون من يومين، ويجب أن يكون تخصصهم مرتبط بالأورام أونكولوجي. شاكرين لكم تفهمكم، ونتمنى لكم يوما أو يومين ممتعين وفائدة ممتدة. Dear colleagues and attendees, we'd like to welcome you in this session, or on these 2-day sessions. We hope that you have an enjoyable and informative sessions. Please be informed that CMEs will be accredited to those who are attending the 2 full days and those who are related to oncology only. Once we are finishing this meeting, you will be receiving an email to evaluate the event, and based on that, you will be granted the CME if you are eligible to the CMEs. For those who are attending on the YouTube, we would like to have you here in Zoom, but the session or the Zoom room is full, so your attendance is not accredited by CMEs, though we wish you an informative stay as well. Thank you all, and we will be back after lunch and after a break and prior. Thank you. please don't share your information on the question and answer box. You should have been shared it in the preliminary registration page once you register to this event. So we have it. So please don't share it here. Thank you very much. Thank you, and we'll see you after this short break.
Okay. Assalamu alaikum and welcome back again. So we will resume our schedule. Now it's my pleasure to introduce Dr. Bassam Suleiman. He is going to talk about the role of immunotherapy in the management of interest in first-line metastatic triple-negative breast cancer. This is a satellite symposium sponsored by MSD. Dr. Bassam is a very dear friend and colleague. He's a consultant medical oncologist at King Fahd Medical City, Riyadh. Please, Dr. Bassam.
Yes, thanks, Dr. Al-Garni, for this introduction. And I would like to thank MSD for organizing this satellite event for discussing the role of immune therapy in management of first-line metastatic triple-negative breast cancer. So this is my disclosure. And I will start with this slide about what's the rationale of using the immune checkpoint inhibitors in triple-negative breast cancer. They noticed that in the triple-negative breast cancer, there is a high expression of PD-L1. Also, there is a high mutation there. And also the tumor-infiltrative lymphocyte is higher compared to the non-tumor triple-negative breast cancer. And I will start with this slide about the anti-tumor immunity is a dynamic process. And once we can see here, from you can see here that the starting of the immunity cycle is starting by releasing the cancer cell antigens. And this release is a spontaneous process actually, but it can be exacerbated by using the chemotherapy, radiation therapy, and target therapy. And this cancer antigen presentation will activate the T cells and trafficking the T cells and infiltrating in the tumor and recognizing the cancer cells by T cells. And by the end, it will cause the killing of the cancer cell. So the question here, where there will be the immune checkpoint will work here in this cycle? Actually, the answer here is that you're working in the last phase, and when the cancer cells will be killed. So by inhibiting this, by inhibiting the immune checkpoint, which is exacerbate the process of immunity. So here I would like to simplify the cancer and immunity. I will start by the right side of the slide that we can see here the immune target, which is the new antigen. This is a protein, but it's abnormal protein that can produce mainly by mutations. And this mutation, and that doesn't mean that this mutation once increased, that increase the efficacy of immune cell. Maybe first person, maybe the increase or maybe not, which increase in the new antigen. The other thing that it can increase the immunity efficacy is the active immune system, the host immunity. It can be cellular immunity here. We have the TILs, the T cell infiltrative lymphocyte. And we have the activation status, which is either there is activators or they're inhibitors, which is this checkpoint. And where is the immune therapy will work? Mainly will work here by inhibiting this break process for the immunity. Once there is no break, the immune system will be active. One important thing before starting also, it's the PD-L1 scoring. It's defining by 3 types of process, either combined positive score, either tumor positivity score, or the IC, the immune cells. So the immune cells, mainly the staining of PD-L1 in the lymphocyte and macrophage. And the TPS is mainly the staining in the tumor cells. And the combined positive score is staining for the 3 cells, either tumor cells, lymphocyte, or macrophage. And the assessment of PD-L1 has a key variables, which is make it difficult here and to take into account for all the clinical trials. It's depending, as I mentioned before, the type of cells, either tumor, immune, or combined. The modality that we are using for the scoring, the calculating, either the combined positive score, which is enumeration of positive cells, or the area occupying of the positive ICs, which using the SB142. Also, we have different cut value. We have 1% or more, 10 or more, 20 or more, or 50 or so. We have different cutoff value. And the primary antibody clone, the most two types that we are using is the SB142, which is mainly for atezolizumab, and the 22C3, which is mainly for the pembrolizumab trials. How's the PD-L1 positivity represented in the TNBC subpopulation? Once we use the SB142 assay, which is mainly in the immune cells, the PD-L1 positivity is represented in 41%. And the T cells, which is different than immune cells, the positivity of T cells here is only 9%, which mainly most of them will be detected by the immune cells, the assay SB142. And once we combine the two different antibody assay and we see how the population will represent each other, we can see once we use the combined positive score with 22C3, the 81% of the population of PD-L1 will be positive. And once we look at the SB142, we looked at all the SB142 positive, the 41, all of them will be included in the population who had combined positive score of 1% or more. Once we specify it for the 10% or more, we can see here that the percentage is 38%, and there is a crossover between the two groups. Around 75% of them will be positive. So once we combine crossing both populations. Now we'll go to the clinical trials who assess the immune checkpoint inhibitors and the advanced stage triple-negative breast cancers. Initially, the monotherapy atezolizumab and pembrolizumab has a modest response rate. As we can see here, once we use it in the first line is 24% and 21. And once we use it for second line and further, the response is much less, compared to be 6 or 5%. And they notice also from the initial trials and as a monotherapy, the responders to the immune therapy, atezolizumab and pembrolizumab, they have a durable response. As we can see here, the patient who had complete or partial response, they continue, the median of overall survival doesn't reach for both trials. Either we use atezolizumab or we use the pembrolizumab. Also, we learn from these trials that the monotherapy responder, the patient who had high PD-L1, high TLS, and the patient who had received the immune therapy in the first lines. This is a trial, Keynote 119, assess the association. We noticed from this slide that there is association between the PD-L1 combined positive score and the overall survival with pembrolizumab and patients who had previously treated with metastatic triple-negative. So once we use the pembrolizumab in the second line and further. So we can see here for the combined score 10 or combined score 1 or the intention to treat, the benefit from monotherapy pembrolizumab is not seen compared to the chemotherapy group. But for the combined score 20 or more, we can see here there is some benefit with the hazard ratio 0.58. Also, the tumor mutation burden, once there is a 10 mutation or more, there is a trend for improvement of the objective response rate, 14 versus 8, and overall survival. We can see here the median improved by with the hazard ratio 0.58 compared to the tumor mutation less than 10. Now I will start with the phase 3 trials who assess the immune checkpoint inhibitor and triple-negative metastatic breast cancer. The first one is the Impassion 130, which assess the addition of atezolizumab to the first-line nab-paclitaxel and advanced breast cancer, which is a randomized, double-blinded, placebo-controlled phase 3 trials. And they randomized the patient to either atezolizumab with nab-paclitaxel versus nab-paclitaxel with placebo, with the primary endpoint is progression-free survival and overall survival. And it's important here to mention that the treatment-free interval for this patient is more than 12 months. For the intention to treat population, the primary endpoint here that was met here with a hazard ratio 0.8, and for PD-L1 population, the hazard ratio 0.63. And once we see for the PD-L1 positive, also overall survival, we can see here the patient with the dark curves, continuous dark curve is more, which is the PD-L1 positive, has a higher overall survival compared to the others, regardless patient receive chemotherapy or not, or patient receive also immune therapy and the PD-L1 negative. As we can see here, the overall survival is for the median for PD-L1 positive is 25 versus 18 months with hazard ratio 0.71. And this is the final overall survival analysis that for PD-L1 positive, using the immune cells positivity population, we, as I mentioned before, that the median is reaching is 25.4 months versus 17 with hazard ratio 0.67. The question that after this trial, because they use only nab-paclitaxel, is paclitaxel will do the same once we use it with atezolizumab? So they did this trials as a phase 3 trial, the same design at all, the same population, and they randomized them to either atezolizumab with Pacli versus placebo with Pacli. And the primary endpoint was progression-free survival in the PD-L1 population, and then if positive, they will do it for intention to treat. And the result was negative here. As we can see here, there is no difference at all in the median progression-free survival, almost the same with a hazard ratio 0.82, which is not statistically significant. And also the overall survival, one of the striking things that the patient who received placebo, the median overall survival, they have 28 versus 22, which is better for the patient to receive on placebo. So why you see this difference with the between Impatient 130 and Impatient 131? With only difference is the chemotherapy, either nab-paclitaxel or paclitaxel. There is a lot of answers. Maybe we know that triple-negative breast cancer is a heterogeneous disease, or there is unknown confounder like antibiotic use or microbes. Or there is the rule of use a corticosteroid that maybe the decreased efficacy of immunotherapy. As with nab-paclitaxel, there is less use of steroid. Or there is difference between nab-pacli and sulfan-pacli dosing, or this is a chance. And just to remind you that all these trials, they use the SB142 for assessing the PD-L1. So initially, there is accelerated approval by the FDA for atezolizumab in 2019, but this approval was withdrawal in 2021 for using the atezolizumab in the PD-L1 positive, triple-negative metastatic breast cancer. Lastly, I will go with this Keynote 355 study, which include the same population, triple-negative breast cancer, but here is more heavily treated. Patient had treatment-free interval less than 6 months. Compared to the other trials, it is more than 12-month treatment-free interval. And they randomized the patient 2-to-1 to pembrolizumab with chemotherapy versus placebo with chemotherapy. And the primary endpoint was progression-free survival and overall survival in the PD-L1 positive, more than 10% combined positive score, and the PD-L1 combined positive score more than 1, and the intention to treat. We can see here the primary endpoint, the Keynote for the Keynote 355, that the progression-free survival and the intention to treat population, there is improvement in the median progression-free survival from 5.6 with the placebo to the 7.5 with the pembro, with hazard ratio 0.82. And once look specifically for the patient with combined positive score more than 10, We can see here that there is more improvement in the median difference, more improvement in the difference between the median progression-free survival to be around 5 to 4 months with hazard ratio 0.65. Once we look for the subset analysis according to the patient population, we can all the groups, regardless of the chemotherapy, they allow in these trials to allow the use to choose the chemotherapy based on the patient and the physician choice, either nab-paclitaxel or paclitaxel or gemcitabine with carboplatin, and they certified them from the initial randomization. And we can see the benefit for adding pembrolizumab to the chemotherapy is regardless of the chemotherapy arm, either nab-paclitaxel or paclitaxel or gem-carboplatin. One of the things that we didn't see the benefit from adding pembrolizumab was the patient who had disease-free interval less than 12 months, which is expected that this patient has only less than 12-month treatment-free interval from the adjuvant setting. Once we look for the chemotherapy regimen and they're looking for the progression-free survival and the PD-L1 combined positive score, we can see here, regardless of the chemo, the benefit is continue, either nab-paclitaxel or paclitaxel or gem-carbo, which is going with favoring adding the pembro to the chemotherapy. Also, for the combined positive score 1 or more, there is a more favoring adding the pembrolizumab, but is less than less as we can see it in the combined positive score 10% or more. And the intention to treat, also the benefit is less compared to the 1 or 10, but we can see for all the chemotherapies, it's more going, the curves going more for favoring the pembro. Looking for the updated result in last San Antonio 2021, we can see here that for patient PD-L1 positive, more than 10% with combined positive score, the median overall survival is 23 months versus 16 months. So there is improvement in the survival by around 7 months or 8 months, with a hazard ratio 0.73, which is statistically significant. And we can see here the benefit of overall survival, the difference mainly in patients who had PD-L1 10 or more, and less be seen in patients with combined positive score 1 or more. Once we see the subgroups for the combined positive score positive, we can see here the benefit of adding pembrolizumab to chemotherapy is less seen in patients with a treatment-free interval less than 12 months. Looking for the objective response rate, adding pembrolizumab to the to patients with PD-L1 more than 10, they have a higher response rate, 52 versus 40, and less efficacy seen in the PD-L1 combined positive score 1%, and the intention to treat also a lesser, as you can see here in the between the columns. What about disease control rate? We can see it's the higher disease control rate, 65% in the PD-L1 positive, more than 10% versus 54 by different around 9%. The duration of the response, one of the important endpoint, we can see here the patient on the pembrolizumab chemotherapy, the median duration of response is 12.8 months versus 7.3 with the placebo arm, and patient with PD-L1 combined positive score more than 10. So I'm reaching to the end that just to compare these 3 clinical trials, the Ambition 131, Ambition 130, and the Keynote 355, that the number of patients included is almost the same, around almost 300 patients, but in the Keynote 355, they randomized the patient 2 to 1. The median disease-free interval is 12 months in the Ambition, but 6 months in the 355, and they include only 20% of their population less than 12 months. The disease with a heavy metastasis, high volume metastasis that involve more than 3 sites is heavy more in the Keynote 355. The chemo backbone, as I know, the chemo backbone here at paclitaxel in 131, nab-paclitaxel in 130, and nab-paclitaxel or gem-carbo in the 355. They allow for all the 3 regimens. Prior chemo to in the early breast cancer, mainly taxanes in most of the trials, but here 22 prior classes list compared to the other Ambition trials. The de novo is almost the same, 30% for all the trials, and the PD-L1 positivity is almost the same, 40 to 45% in all the trials, but they use different techniques. Lastly, I will end by this guidelines that the NCC guidelines in last edition, last version in 2023, they recommend for patients with PD-L1 positive, combined positive score 10 or more, regardless of the germline BRCA mutation status, to use pembrolizumab with chemotherapy, regardless of the chemotherapy arm, which is category 1 as and preferred. For the ESMO guidelines, for PD-L1 positive, they allow for both atezolizumab with nab-paclitaxel or pembrolizumab with the chemotherapy, regardless what type of chemotherapy. What's next? I think many targeted therapy now investigated, the PARP inhibitors, the androgen inhibitor, all coming, and the combination with IO chemotherapy maybe show some promising result, which is coming later. So this is my summary. Response to immune checkpoint inhibitor monotherapy in metastatic triple-negative breast cancer are modest. And we can see the factors that increase the efficacy mainly once we use it in the first line, patient with high expression of PD-L1 level, and the patient who had tumor infiltrative lymphocyte is high, or tumor mutation burden is high, more than 10. Also, the pembrolizumab with nab-paclitaxel or gemcitabine and carboplatin, approved for the first-line therapy in PD-L1 advanced who had PD-L1 combined positive score 10 or more using the DACO 22C3 assay. For the clinical trial needed to answer the open clinical question, one of them is how is the combination with checkpoint inhibitor and targeted therapy like MEK inhibitor, AKT inhibitor, or PARP inhibitor for metastatic triple-negative is promising in the phase 2 trials and phase 1. And maybe we are waiting for the phase 3 trial, which is ongoing. And thank you.
Thank you very much, Dr. Bassam. Any question? Let me check the Q&A. Jason, can you have the book for the next? So I don't see any question from the audience. So just quick question, Bassam. So now the use of immunotherapy, as you mentioned, pembrolizumab with CPS more than 10, maybe this is the right patient to use immunotherapy. So my question is about the backbone chemotherapy that you're gonna use. Is the use of steroid still a concern for you with all this study as a pre-medication and medication for nausea and vomiting? Does this affect your choice of chemotherapy or not?
Sorry.
So the use of steroid as a part of chemotherapy protocol, would it impact your decision and choice of chemotherapy backbone?
No, it's not impact my decision for using the dexamethasone. It's small doses, but it's not that affecting the role of immunotherapy. But what's regimen of chemotherapy I prefer? All of them is be used, but I prefer specifically for de novo metastatic triple-negative. I'm referring the paclitaxel. Okay. With the pembrolizumab for PD-L1 positive, yeah.
Okay. Any more question? Okay. Thank you very much, Dr. Bassam. Now we'll move to the second satellite symposium. It's about the Abran's real-world data in metastatic breast cancer. Okay, it will be presented by Dr. Sharif Kulab, who's a consultant medical oncologist at King Saud University Medical City. Please, Dr. Sharif.
No. This is not a good one. This is not a good one. Change a lot between testicular and breast. Whole discussion is good. Yes. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. First, I'd like to thank Dr. Nafisa, Dr. Muhammad, Dr. Sadal, and all the organizing committee for this conference, for getting me this opportunity to participate in this conference and to collaborate with our colleague from Pfizer company that I'm thanking also, in order to discuss today the last data presented recently last year in ASCO 2022 about the role of palbociclib, the combination with hormonal treatment in the treatment of metastatic luminal profile breast cancer. With some focus on the last presented real-world data in this field. This is the disclaimer, and this is my disclosure. And this will be, inshallah ta'ala, the plan of my presentation. First of all, I want you to look on the response rate that we can obtain by hormonal treatment over the last years. Since the first hormonal treatment has been introduced in breast cancer, the response rate in the metastatic setting was not exceeding initially 30 to 35%, until we reached the aromatase inhibitor, steroid or non-steroid subtypes, and the response rate reached to be started to be around 40 to 45%. And with Faslodex, we are talking about only hormonal treatment monotherapy. The response rate was increased to 50 to 60% roughly. Just keep this in mind, because we are going to use and compare this with what we are obtaining by the combination of CD46 inhibitor and hormonal treatment. Before going through the trial, the data in the literature, we need to differentiate between the hormonosensitive, hormononaive patient cases situation and the hormonoresistant patients or situations in breast cancer, in luminal profile breast cancer. And among the resistance, we need to differentiate between the primary and the secondary endocrine resistance. As you know, the primary endocrine resistance, when it comes to the adjuvant setting, usually it means a recurrence during the first 2 years during the adjuvant treatment. And the patient is on metastatic setting. We are referring to sensitivity, endocrine sensitive, endocrine primary resistance when the recurrence is coming during the first 6 months. The secondary endocrine resistance is usually at the adjuvant setting happening after second year of hormonal treatment, after completing at least 2 years. And when it comes to metastatic setting, it is after 6 months of treatment on the metastatic setting. Data are differentiating between primary and secondary endocrine resistance. Have a look about the effect that we are maintaining, what we are getting by using the hormonal treatment, the different types of hormonal treatment for at metastatic setting, for metastatic luminal profile breast cancer. With tamoxifen, in absolute difference in median value, we are getting 6 months. In aromatase inhibitor, we are getting 13 months, almost the double. With Faslodex, 16 months difference. And when it comes to combination of CD46 inhibitor and letrozole, we are getting a different mean value, absolute value of 25 months. This is in the endocrine sensitive, okay? Endocrine sensitive metastatic luminal profile breast cancer. In the endocrine resistant metastatic luminal profile, these values are almost the half. You can see with exemestane we have 3 months, with Faslodex we have only 5 months, and with combination of CD46 inhibitor we have roughly the half of what we are obtaining in the endocrine sensitive situation. This is the first message that I need to deliver. The data are differentiating between endocrine sensitive and endocrine resistance. And in endocrine resistance between a primary and secondary, they are not the same. And we need to keep this in mind. This is a summary of the major important CD4/6 inhibitor combination with hormonal treatment in metastatic luminal profile of breast cancer. They look the same, roughly, with some differentiation among these trials. First trial is PALOMA for palbociclib, Monarch 3 for abemaciclib, MONALEESA 2 and MONALEESA 7 for ribociclib. All of these trials are phase 3 randomized, double-blind, controlled trials. In all these trials, the primary endpoint was the progression-free survival. The progression-free survival was the primary endpoint in all these trials. In PALOMA 2, palbociclib has been compared to palbociclib plus letrozole has been compared to letrozole alone in 2-to-1 fashion or randomization, and they have included more than 600 patients in this trial. In Monarch 3, abemaciclib has been compared with a large spectrum of hormonal treatment, non-steroid aromatase inhibitor, with abemaciclib versus hormonal treatment alone. Roughly 500 patients were randomized with the same randomization fashion, 2-to-1. MONALEESA 2, again, for the same profile of patients, postmenopausal patients until now, more than 600 patients have been randomized in 1-to-1 fashion to receive ribociclib plus letrozole or letrozole alone. In MONALEESA 7, one particularity, premenopausal patients have been accepted in this patient, premenopausal and perimenopausal patients. More than 600 patients have been randomized in 1-to-1 fashion to receive ribociclib plus tamoxifen or any other hormonal treatment, or ribociclib, sorry, it is not palbo, or ribociclib down, plus tamoxifen or any type of hormonal aromatase inhibitor. Primary endpoint was, again, progression-free survival. All these trials were positives in PALOMA 2, MONALEESA 2, and Monarch 3. Progression-free survival was significantly higher in favor of the combination of CD4/6 inhibitor and hormonal treatment. Curves are very clear. They are separating since the beginning, and they continue to separate. And what is important for me to look at is the hazard ratio. Hazard ratio in all these trials is consistent with around 0.55, 0.56, 0.57, around this range. In terms of number, this is a busy slide, but just to give you an idea about the absolute difference that we might get. With PALOMA, we are getting benefit of 13 months difference in favor of the combination. With MONALEESA ribociclib, we are getting roughly 9 to 10 months. With Monarch 3, we are getting roughly 1 year, 13 months, the same as for PALOMA. This is an absolute difference, but what is more important to keep in our mind is the hazard ratio, as I said. According to these results, all these trials have achieved the primary endpoint, and the combination of CD4/6 inhibitor and hormonal treatment has become the standard of care in all these trials, as per NCCN, European guidelines, and the ABC guidelines, and different national or international guidelines. Secondary endpoint in this trial was the overall survival. Overall survival, I emphasize on this, was a secondary endpoint in all these trials. In PALOMA 2, Monarch 3, MONALEESA 2, and MONALEESA 7. For ribociclib, the first and the only one so far who has shown a significant improvement in terms of overall survival in favor of the combination of ribociclib and hormonal treatment. And as you can see, the median value of overall survival is passing from 51 to 63 months with roughly 13 or 12 months difference in terms of absolute difference. Palbociclib did not show a statistically significant improvement in favor of overall survival in favor of the combination. But we are talking here about the whole population in the intention to treat population. So it was negative trial. As you can see, the hazard ratio is 0.95 roughly, and the median value of overall survival is 53 versus 51. For Monarch 3 trial, it seems that there is a signal for the separation of curves, but still we don't have the final, terminal analysis of this trial. At the interim analysis, when they presented this trial last year in the ESMO, there was a separation of the curves. Median overall survival is passing from 54 to 67 months. And this difference with a p-value of 0.030 is not significant as per the analytical plan for this trial. So far, there is difference, but this is not the final, but this difference is not significant, and this is not the final analysis of this trial. So just to summarize, in terms of hazard ratio, progression-free survival, It is improved with a hazard ratio of around 0.54, 0.56, 0.57 in all these trials. Overall survival has been achieved only for ribociclib so far with a hazard ratio of 0.7, 0.76, as you can see. For palbociclib, when we look to the whole population, it has not been achieved with a hazard ratio of 0.96. For abemaciclib, we are waiting the final analysis. There is a signal, but this difference is not yet significant. In terms of curves, you can see here on the bottom of the slide, and in terms of benefit, absolute benefit in terms of overall survival, we are getting with palbociclib in PALOMA 2, only 3 months. In MONALEESA 2 with ribociclib, we are getting roughly 1 year or more. In Monarchy 3, we are getting roughly the same thing. Let's have a look on the PALOMA 2 trial. Just to remind you, the PALOMA 2, again, is a phase 3 trial of combination palbociclib plus hormonal treatment with letrozole in this trial. And this is usually our usual prescription in our patients. More than 600 patients, 666, have been randomized in this trial in 2-to-1 fashion randomization to receive either palbociclib plus letrozole or placebo plus letrozole. Primary endpoint for PALOMA 2, as for any other CD4/6 inhibitor trial, was progression-free survival, not overall survival. In secondary endpoint, we find overall survival, and we can find some other criteria and safety profile as well. PALOMA 2 primary endpoint, as we showed, was PFS, has been shown to be significantly improved with the combination. And progression-free survival is passing, the median PFS value is passing from 14 to 27 months, with roughly, again, 13 months benefit in terms of PFS. Have a look on the distribution of these patients. We have 666 patients who have been randomized in 2-to-1 fashion. And at the time of analysis, we have noticed that there was almost 13% of patients who have received palbociclib have missing data. On the other hand, among patients who received placebo plus hormonal treatment, we have roughly 21% of patients who have missing data. This 21% for me is more important than the 13% in the control group, because the randomization is 2-to-1, and 21 here is equivalent to 42 roughly for the whole population. So this missing data is considered high. More than 10%, there is a high risk of bias. More than 20%, there is a clear bias and in the data interpretation, and we need to be careful when we are looking for that. Of course, missing data is because some patients are withdrawing their consent. And one more criteria for me is more important, is the lack of follow-up of some patients in this trial, something that has been done well in other trials. Another thing, at the time of analysis, we have some patients who were still on ongoing treatment. 10% of patients still are ongoing treatment and have not been sensorized for the analysis in this trial, versus 2% in the patients who are receiving placebo. Have a look again on the overall survival curve for palbociclib plus letrozole. There is absolutely no difference, no improvement of overall survival in the whole population, as you can see. Curves are similar, they are the same, hazard ratio is 0.9056. But let's have a look on the subgroup of patients in this trial. If we look to the subgroup of patients, considering the missing data that we have talked about, we can find that the subgroup of patients who have a maximum of disproportion of missing data is the subgroup of patients with excellent performance status. We have 11% versus 28%. Once again, according to the randomization, this 28% is very high and is considered as 56% missing data in the whole population. So once again, this maximum disproportion has been observed in the patient who are with best performance status. As you can imagine, the patient with good performance status are the best candidate for the trial usually. On the other hand, if you look to the subgroup of patients who have the least disproportion of missing data, we find this in the patient who had the worst performance status, a patient who had a recurrence more than 1 year, and mainly the patient who have received an endocrine therapy, and the patient who received also a chemotherapy. So in PALOMA 2 Pfizer tried to do a post-hoc analysis by considering this missing data and to exclude the patient who had affected or diluted the data for the interpretation. What happened? After eliminating these patients, the overall survival has been improved. As you can see here, the curves are started to separating, and the hazard ratio is at around 0.86. Still, the difference is not significant, but improved. And they tried to accumulate the data from Paloma 1, which is a phase 2 trial, and Paloma 2, phase 3 trial of the same design, palbociclib and letrozole. And when they did like this, when they accumulated all the data from these two trials, and they tried to look to the overall survival in the subgroup of patients who had a recurrence after 1 year with the least missing data subgroup, they found that this difference is becoming significant in favor of the combination. And again, look at the hazard ratio, it is around 0.736, the same hazard ratio range that has been observed with ribociclib and to some extent with abemaciclib so far. Another thing that we need to keep in our mind, after the trial, what is the treatment that our patients are going to receive? As you know, palbociclib was the first coming to the market and the first one who had approval by FDA. And since the beginning, we started to give palbociclib to our patients. So after the end of this trial, the patients who were on a placebo were allowed to receive palbociclib later on. That's why we have 24% of patients who received the placebo before, they are going to receive palbociclib later on. And we are considering the overall survival by recruiting these patients. So this is again another point which might impact the overall survival and needs to be looked at carefully in interpretation. So have a look on the effect of palbociclib in terms of disease-free survival when we look to the PFS, progression-free survival in whole population. You can see it is talking here, it is significant in favor of both group, progression-free survival. But when it comes to the overall survival, we are missing data here. We find that this difference is observed only in the group of patients who had a recurrence after 1 year, where we are not losing a lot of data. In the group of patients who have recurring disease in less than 1 year, there is a high proportion of missing data, as you can see here, 12 to 29%. And in this subgroup, we cannot find this difference in terms of overall survival. Another point, again, is a very important point we need to look at, is the treatment-free interval and the disease-free interval. We need to differentiate between these two concepts. The disease-free interval is the time from diagnosis until the death. The treatment-free interval, the TFI, is the interval running from the end of the adjuvant treatment until the death. When we are talking about PFS, we are not looking at these two variables because we are not looking to the whole overall survival. But when we are talking about the overall survival, these are the concepts that we are using. And just keep in mind that they are not the same in whole CD4/6 inhibitor. Some trials, they are using the TFI, and they need to refer to that in their protocol in the same way. And other trials like Paloma 3 is the same as Paloma 2, but with Faslodex, not with letrozole. They use the term of DFI. As you can see, DFI is higher than TFI. So we are expecting a more, maybe false positive impact in overall survival. So we need to be careful when we are talking about TFI and or DFI, and we need to refer to that, to the protocol as well, not only in the interpreted, presented data. This is what we have mentioned about the missing data. Missing data less than more than 20%. This is pose usually actually serious threats of the trial, and more than 10%. This is a direct bias in the interpretation. This is an important slide, in my opinion, I want you to look at. This is a report that coming from the National Cancer Institute. They did the kind of scientific committee in collaboration with other committees in order to define the primary endpoint that we need to use and define in the trial and to build our decision according to this. In HER2-positive disease and HER2-positive HR negative, pure HER2-positive disease, and in triple-negative disease, these are the worst scenario, the worst cases of a breast cancer. We need to have an improvement of overall survival in order to consider a drug impacting on the life of patients and to have approval later on. However, on the other hand, if you look to the HER2-positive, HR-positive, and mainly to the luminal profile, pure luminal profile, primary endpoint with PFS value significant improvement is enough to consider the trial as positive and to consider the validation of the drug in terms of drug registration. So the message here is PFS in luminal profile as primary endpoint is enough to consider registration for the trial. So conclusion from PALOMA-2, since the last ASCO, PALOMA-2 has met its primary endpoint, which was the progression-free survival, as other CD46 inhibitor trial has shown as well. The overall survival was not significantly improved in favor of palbociclib, but with a lot of cause or interpretation, mainly the missing data, which might affect these results. If we are considering the subgroup of patients where we are not missing data, we might have an improvement of overall survival with palbociclib. So just have a look now about some real-world data about palbociclib letrozole in the literature. You know, since 4 or 5 years, we started to have a lot of real-world data. We have different trials that has been presented in the United States and Canada, USA and Europe, and other countries also in the world. Some of these trials were based in the Flatiron database. You know, the Flatiron database is the healthcare system database in the United States, where more than 2.4 to 3 million filed patients can be reviewed, and hundreds of trials have been reported according to these data. So this is a kind of retrospective analysis. We are looking to the usual day of the patients, of the physicians, how they are treating their patients, in which type of hormone treatment, and the behavior of their patients. So the Flatiron first trial that has been presented, one of the recent trial presented 1.5 or 2 years back, was the Flatiron data-based trial. In this trial, they tried to look to roughly 2.4 million filed patients, and they looked to 1,400 patients who received either palbociclib and letrozole, and patients who received letrozole alone. And this is the retrospective analysis again. The primary endpoint in this real-world data was to look for the PFS and the overall survival without considering the menopausal status for this trial. More than 1,400 patients were reviewed. The inclusion criteria were the usual criteria that we're using: adult patient diagnosed with metastatic breast cancer, a luminal profile, and it ran between 2015 and 2019. The patients who have been treated between 2015 and 2019. The primary endpoint, again, is PFS and overall survival. We wanted to have a look over that. Small word, this is the retrospective analysis. There will be a bias in the interpretation, and that's why there will be a need to use some statistical method. One of these methods is the propensity score matching, and another score called the inverted probability. We know this score from the early trial in breast cancer that has been validated, the letrozole in the adjuvant setting, because since that time we started to use this concept in order to have a homogeneity of our patients, to eliminate the non-representer in this patient, in this subgroup, and to have a good comparison of the patient. So we might use some statistical method in order to eliminate the odd patient and to have a homogeneity of the trial. Primary endpoint was primary PFS, and as you can see here, in this trial, the PFS was improved from 12 months to 20 months. We were getting benefit of only 8 months in the real life in this trial. Overall survival seems to be improved. We don't have a final value for the treated patient with palbociclib so far. This is the interim analysis. But the median value for the placebo, for the letrozole hormonal treatment alone, was 43 months, similar a little bit to what we have observed in the phase 3 trial. This benefit in terms of PFS was observed on all subgroups, and also this benefit of overall survival has been observed in all subgroups of patients. Coming to the reality X, the last real-world data that has been presented in the last ESMO, I guess, it was again the same thing. We wanted to look at the patients who received palbociclib letrozole versus the patient who received only letrozole, aromatase inhibitor generally, so letrozole or aromazine or arimidex. Primary endpoint was PFS and overall survival both together. So in this trial, again, we found an overall survival improved and PFS improved in favor of the combination. The PFS, the overall survival is improved by 13 months roughly. And even after application of the statistical method, we are observing the same difference. That means there is a homogeneity of the group. The hazard ratio, have a look on the hazard ratio, it is 0.67, 0.7, 0.72, almost near to what have been observed in the phase 3 trial. And this benefit in terms of overall survival has been observed in different subgroups of patients. Also in terms of PFS, this is the same thing. We are getting a benefit of 5 to 6 months, much less than what has been observed in the phase 3 trial, but this difference seems to be significant with the hazard ratio of 0.67, 0.7, 0.72. So the strength of the real world data of RealityX trial and other Flatiron-based database analysis and any other real world data is that we are using retrospective. One of the important point is that we are using a large number of patients in this retrospective analysis. They analyzed more than 3 million file of patients and more than 1,400 patients have been recruited. And there was a comparative group. So we have patients with palbociclib, hormonal treatment, and we were having patients also with hormonal treatment alone. So we were able to compare, especially if we are applying some statistical method in order to conclude in a better way for the real life PFS and overall survival. The limitation of this kind of trial is the limitation of all retrospective trial. This is the retrospective trial. Even with the application of some statistical method, there is a biased risk that we might take. And some subgroups of patients in the analysis might not have enough number to be interpreted for the trial. And this is again one of the bias. So the conclusion of RealityX, the last real world data that has been presented, and of all other palbociclib combination hormonal treatment, is that the results that we are obtaining with RealityX and other Flatiron-based data analysis are roughly the same, similar to what have been observed in phase 3 trial, with the clear improvement of PFS and also of overall survival. This is just a direct combination, indirect comparison between the PALOMA-2 and the RealityX to give you an idea about the difference between phase 3 trial, randomized control trial, and the retrospective analysis in real world data. In PALOMA, this is a randomized control trial, phase 3 double blind. And we are defining here the primary endpoint since the beginning, and we are recruiting the patients with very strict inclusion and exclusion criteria. In RealityX, all data, Flatiron database, real world data, this is the retrospective analysis. There are some inclusion and exclusion criteria, but we are not very strict. One of the major important thing is the number of patients. In phase 3 trial, we are recruiting a small number of patients relatively to what we can observe in the other real world data. Here we have 666 patients, and here we have roughly 3,000 patients who have been recruited. The enrollment for phase 3 trial usually is short, over 6 months, 1 year, 2 years. For the real world data, we are taking the file of the patients over 4, 5, 6, 7 years, like this. One of the risks that we can take in the RealityX, there is no central review, and we are relying our information to what have been written in the file. Some physician might write all full data, and some patients might take the risk and not fulfill all the information required in the file of the patients. And we are taking the information from patients' file. So there might be a bias in this interpretation. The dose in the randomized control trial is 125. If there is a toxicity, we are going to 100. If there is toxicity, we are going to 75. The protocol that you know. But in the real life, all those are there. And it happens to me, and maybe for you as well, that we might prescribe 75 directly at the beginning, especially for elderly fragile patients, or 100 milligram, and so on. Other difference are matching the difference between the randomized control trial and the retrospective data analysis. Primary endpoint in randomized control trial was PFS. Overall survival was secondary endpoint. In the real life data, we can consider PFS or overall survival because this is an observation of patient's file and patient data. One of the important things in the real world data that it allowed us to recruit male patients with a breast cancer, and following to real world data, there was an approval of using combination of palbociclib and hormonal treatment and other CD46 inhibitor, of course, with hormonal treatment in male patients with humanly profiled metastatic breast cancer. So to summarize, all CD46 inhibitors trial have achieved their primary endpoint, which was significant improvement of PFS. Secondary endpoint was overall survival. So far, it has been observed only with ribociclib. Has not been observed with palbociclib. but with very careful interpretation of the results. If we are considering subgroup of patients, eliminating the risky group of patients where we are missing data, and considering the good definition of TFI and DFI, we might observe an improvement of overall survival of same range in terms of hazard ratio as what we have observed with ribociclib, and to some point what we might observe with abemaciclib maybe this year in the final analysis. This difference and this benefit in terms of overall survival has been observed in the real world data, encouraging us to prescribe the CD4/6 inhibitor and hormonal treatment, and this is the standard of care so far for first-line treatment of luminal profile breast cancer patients. With this, I end my presentation. I hope I was clear. Thank you for listening.
Thank you very much, Dr. Sharif, for this excellent overview about the CDK4/6 in the metastatic setting. And we have maybe 1 minute for one question. So our last question. So you have presented, all the three agents that we have. So some of them, all of them actually show progression-free survival advantage, and you have one agent that showed overall survival advantage. So would this make an impact in your choice of what CDK4/6 you would use in your clinic?
To be honest, this is the major question that we are discussing today, and this is a difficult question. But maybe I will answer by asking the question in another way. Are they the same or they are not the same? I guess they are not the same in terms of efficacy, and in terms of side effects, tolerance profile. I will just get some emphasis over some CD4/6 inhibitor according to their trial interpretation. Ribociclib has the advantage to be the only one who has been presented or tested in premenopausal patients, perimenopausal patients in one specific trial, something that has been done specifically in other trials. So this is one advantage. Abemaciclib has one good advantage is that it has shown so far an impact in terms of overall survival, disease-free interval in adjuvant setting. Palbociclib did not show that. Trials are not the same, and there are a lot of bias there and a lot of differences in terms of trials. This is in terms of efficacy. So there is a lot of differences in some points in terms of efficacy among making difference among these three CD4/6 inhibitors. In terms of safety, we know that hepatological toxicity is not the same. We have maybe more hepatological toxicity with ribociclib, to some point with abemaciclib, less with palbociclib. We have more GI toxicity with abemaciclib compared to ribociclib and palbociclib. So the profile is not the same. One thing I need to mention is that there was a committee that has been created also with the National Cancer Institute, and giving an impact factor to each drug according to the efficacy and the tolerance profile. And they said level 1 and level 2 will be accepted. To accept this drug will be accorded to accept this drug as best drug or level 1A recommendation, if they are getting level 1 or level 2 of point. And they were creating the point according to impacting it by impact factor. For example, efficacy, PFS, overall survival, the side effects. The best one that who has shown was ribociclib with level 1 recommendation, 1A recommendation. Abemaciclib and palbociclib has come in just after, but with same level of recommendation, 1A, 1A. But we have to say that ribociclib has been considered by this committee as better than this. In terms of safety, maybe, I'm talking about safety only here.
Okay, that's very clear, Dr. Sharif. Thank you very much. And now Dr. Nafisa will take over for introducing the next session. Thank you.
Hi, good afternoon. Welcome to session 2. Actually, it's my pleasure and honor to introduce two dear friends to me. This session about hereditary breast cancer. The session will be chaired by two strong ladies, Dr. Nashmiya Al-Mitari. Dr. Nashmiya is a consultant gynecology, and she's the head of the Gyne-Oncology section at King Abdulaziz Medical City. The other lady is Dr. Lulu Reyes, who is a breast surgeon, and she is the head of breast surgery at King Abdulaziz Medical City. Welcome, Dr. Nashmi and Dr. Lulu, and you can start the session. The title of the session, as I mentioned, is about hereditary breast cancer. Please.
السلام عليكم. السلام عليكم. Thank you, Dr. Nafisa. Assalamu alaikum. Thank you, Dr. Nafisa and organizing committee for the invitation. Now we'll start our session in the hereditary breast cancer. It's my pleasure to introduce our first speaker for this session, Dr. Mohammed Al-Garni. Dr. Mohammed, he is a consultant and the division head of the Cancer Control Program at King Abdulaziz Medical City, Riyadh. Dr. Mohammed, he will be presenting to us the clinical utility of genetic testing in breast cancer beyond cancer risk assessment. Please, Dr. Mohammed, the mic is yours.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Nashmi, for the kind introduction. So my task is to talk about the clinical utility of germline testing for breast cancer patient beyond cancer risk assessment. So genetic testing become more and more relevant to cancer care, not only for breast cancer. However, it was mostly studied in patients with breast cancer. So this is the typical referral that we see in our clinic from different cancer type. Colon and breast and ovary represent the majority of the referral that we see. Part of this related to that these two cancers, especially the colon and breast, are the commonest cancer diagnosed in our country. And at the same time, it's the commonest cancer associated with hereditary component. So the question why we need to do genetic testing, and if we look to the hereditary cancer syndrome in general, and even for patients with breast cancer, the use of information that we get from the genetic testing is not only about cancer risk assessment or estimation of lifetime risk assessment. As a matter of fact, it helps us to know the prognosis. Sometimes it has a predictive value. It helps us to do certain prevention and screening recommendation and therapeutic intervention. And at the same time, it's help us to personalize this intervention, and we don't apply the one size fits all. Based on certain genetic mutation, we can do certain personalized intervention for the individuals. One of the success story for this is the BRCA gene mutation. As you can see since the discovery of BRCA gene in early 1990, where we use that as a predictor and known to be associated with increased risk of breast cancer and implementation of prophylactic mastectomy since that time. However, if you look after 3 decades of discovery of this gene, now we use the information to treat the patient in metastatic setting as well as in the adjuvant setting. So the use of genetic testing information help us as a medical oncologist to decide about the use of certain agent, for example, platinum-based chemotherapy or PARP inhibitors. It helped the surgical oncologist or the breast surgeon to decide about the risk reduction surgeries. The radiation oncologist also, they can utilize this information. In addition, it aids in the reproductive decision and the family screening as well. So what to test? There are different way of doing genetic testing. Some of them is doing the blood test, where you look for the germline mutation. The other thing is you test the tumor and trying to find the mutation in the tumor itself. And the one that is more evolving is doing both actually, which is testing the tumor and at the same time doing the blood test. Now, each one of these approach has pros and cons, especially the last two, one, when you combine germline and somatic, the cost is really going to be high, and at the same time, the interpretation of the result needs certain expertise. This is a study that showed more than 246 individuals. They have somatic mutation, and if you follow only the or testing only the tumor without doing the germline mutation, probably you miss about 59% of patients who carry BRCA1 and BRCA2. So looking or testing for germline mutation, BRCA1, BRCA2, and others should not rely only on the molecular profile, and you have to do genetic testing. These are the common gene associated with hereditary breast cancer. The most common and well-studied is BRCA1 and BRCA2. There are other multiple gene mutation, including TP53, PTEN, and other. Some of these mutation has high penetrance mutation, and some of them they have low penetrance or intermediate penetrance. The way we go with the testing is the panel testing, despite some limitation in terms of the using a panel test. So it's better because you can test for multiple genes at one time. The cost is reasonable and it's less syndrome specific. And maybe you don't need to rely a lot on the family history if you do the panel testing. However, the cons also is the interpretation of the results sometimes can be challenging. There is a high chance you will find variant of a certain significance. And sometimes it might lead to over-treatment and over-screening. So whom we should test? There are multiple ways of looking to the population that need to be tested. There are multiple available risk assessment model, like the Manchester IBS and BRCA Pro and others. All these models has also its own limitation, has the pros and cons. The time is not it's not the time to discuss all of this. However, it can help and can aid in the decision about whether you should do testing or not, but we don't rely only on this risk assessment model. The testing criteria, we have the NCCN guideline and other guidelines that can help you to guide whom should be tested. Ethnicity, of course, the judgment and depend on the pathology. For example, triple negative breast cancer, all of them, they have to be tested regardless of their family history. And also it's important if this is going to affect the management of patients. These are the NCCN guideline for screening. The last two, as you can see, if you are considering PARP inhibitor in the management of patient or patient who's newly diagnosed and potentially eligible for PARP inhibitor. So basically you are including more or most of patients with breast cancer. And this brings us to the NCCN guideline or the screening guideline and whether it's efficient to detect the patient with germline mutation. We know that these guidelines has limitation. And if you restrict yourself to these guidelines, you are probably going to lose or to miss some patient with germline mutation. However, this is what we have available so far. And the movement, moving forward with this, I think we are coming to the universal germline testing for all comer for patient with breast cancer. I'm going to show a slide for this. However, this is a picture or a slide for patient with infiltrative lobular carcinoma that classically, maybe we don't think about it as a hereditary apart from the CDH mutation. However, in this study, they looked for large cohort of patients and they found it's relevant that BRCA2, CDH, and CHIK2, and probably BALB2 also incorporated in the pathogenesis of patient with infiltrative lobular carcinoma. This is what I was mentioning about the universal germline testing. So universal germline testing means testing all comer regardless of their family history or their pathology. It has been established in certain cancer like ovarian cancer. So all patients with high-grade serous ovarian cancer, you test them for BRCA mutation. However, a study done in patients with breast cancer showed that there is a chance that you increase detection of germline mutation if you test all patients. And at the same time, there is a chance that you will change the management based on this finding. However, it comes to the issue of access and the cost of doing all of this. So this is our data for our patients from National Guard Hospital, more than 300 patients, doing the comprehensive hereditary panel for them showed that if you test only for BRCA1 and BRCA2, it has been reported before in our population, about 11%. But if you do more expanded panel, you are increasing the chance of detecting pathogenic mutation, and the rate will be 16%. And the special population on this study is the triple-negative breast cancer, who are at high risk of carrying this mutation. Despite all of this, still there is a lack or gap in doing the genetic testing. Some of them incorporated into the awareness, some of them incorporated to the access to the genetic testing and the cost of genetic testing. This study was done in the United States for more than 10,000 individual. Medical record was reviewed in a COBE accredited center, and they looked for the patient who met the criteria for genetic testing and were referred to genetic testing. They found in breast only half of them, and in the colon cancer, it's even worse, about only 26% of patients were referred. So there is still under use of these tests, and we need to work more in the awareness about this testing. And this brings us to how to improve the access to genetic testing. So there is a two different pathway: the traditional model, genetic counselor nurse, where this is still implemented in most of the places in the world. And the other one is the oncologist-led mainstreaming model, which is incorporated in our center, that has the advantage of easy access and quick access and obtaining the result in a timely fashion, especially we are in a time that we need the information to decide about surgical and medical management. Of course, when we approach someone with hereditary or germline genetic mutation, we don't deal with the mutation as the same. There are different. The risk of lifetime risk cancer associated with this is different. And based on this, we decide about our approach to those individuals. As you can see here, BRCA1 and BRCA2, this is for breast cancer patient, the highest risk of developing breast cancer. BALB2, which is, we deal with it as a more of BRCA2 mutation, also carry higher risk. However, if you look, for example, to the RAD51D or C, the lifetime risk is not really significantly high compared to the BRCA1 and BRCA2, and hence our approach of intervention is different. Also, something we keep in mind when we approach someone with genetic mutation, there is a variation in the expressivity. So not all BRCA2, for example, will express ovarian cancer or breast cancer. Each family, they have sometimes certain cluster of certain type of malignancies that we need to individualize our approach based on the family history as well. If you see the lifetime risk for patients with BRCA2 and BRCA1, it's widely variable. Some studies showed 50%, and some studies showed 85%. And this is basically related to different population that was studied. Some population, as Ashkenazi Jewish, it's very high rate to detect BRCA gene mutation in those populations. So the range is variable, and there are efforts trying to know what is the individualized risk of cancer. So when we say BRCA1, their lifetime risk is 50 to 85%. This is all BRCA1 mutation. But what about the patient that's sitting in the front of you? Still, we are doing more work and many things to be done, trying to reach to this point. However, one of them is the polygenic risk score, which help to identify the individualized risk for certain type of cancer. It has not been approved yet, but it's something being studied well, and I think it's going to come soon. One of the most cheap and easy way to estimate the lifetime risk is presence of family history. So if you have a BRCA mutation patient sitting in front of you and they have more than 2 members, they have breast cancer, their lifetime risk is really high, and you need to be aggressive with the risk reduction intervention with those population. So patient also with ovarian cancer, they have a different time or different lifetime incidence of ovarian cancer, depending on BRCA1 and BRCA2. And this is the reason of the recommendation of considering prophylactic surgery for BRCA2 later compared to BRCA1 patient. So BRCA2 patients tend to develop ovarian cancer later in their lifetime. Another mutation that I just mentioned before is the PALB2, which is we consider as a BRCA2 mutation. It's associated with significant increased risk of breast and ovarian cancer as well. And if you can see here, also the presence of family history is a very important indicator of high chance of developing certain malignancies. Multiple options that we have trying to reduce the risk of hereditary breast cancer. Some of them are chemoprevention, surgical, and the approach is different from one patient or one individual to another. And the key of this is that this is a multidisciplinary care that you need to incorporate multiple services in order to provide the best risk reduction intervention for those individuals. Moving forward with more trying to personalize the risk reduction intervention. This is one of the studies that being done looking to performing salpingioophorectomy compared to salpingioophorectomy in patient with BRCA1 mutation, because there is a theory that most of the ovarian cancer in BRCA patient originates from the fallopian tube. So they are trying to address this question. It's not a standard practice. Some places in the world they are doing this, but it's not the standard. And as of today, we have to do the bilateral salpingioophorectomy. What about the rank ligand in patient with BRCA mutation? Some studies showed that there might be a preventative role for using denosumab, for example, in patient carrying BRCA mutation. And this is an ongoing phase 3 study trying to address the preventative role of denosumab in those patients. And also moving forward with the prevention using of olaparib as a preventative tool in patient with BRCA mutation has been studied in the animal model, and it's being investigated in the phase 1 study as well in the human. So to summarize, I think the assessment and testing for hereditary breast cancer predisposition syndrome should be a part of breast cancer management. We need to work together to improve access to genetic testing. Multi-gene panel is the preferred way of doing genetic testing. We should individualize our approach for screening and prevention, and we should remember that it's a multidisciplinary approach. And by this, I conclude. Thank you very much.
Thank you very much, Dr. Mohammed. Thank you for sticking to time. I'd like to welcome to the podium Dr. Sadel Al-Rufai, a dear friend of mine. Thank you, Dr. Sadel. Dr. Sadel joined the National Guard Hospital as a consultant oncologist for the past 1 year, at least more than 1 year. And she's part of the training program. She's part of our clinical trial group. And she's graduate from France. And she's been working there as an associate consultant for the clinical phase 2 clinical guideline, clinical trials. Dr. Sadel.
Thank you, Dr. Lulwa, for the kind presentation. Well, thank you, Dr. Nafisa, Dr. Mohammed, for having me today. So, Bismillah wa salatu wa salam ala Rasulillah. Today, I was asked to talk about the adjuvant therapy for BRCA positive and hormone receptor positive breast cancer. So in this slide, we are redefining the breast cancer biology. Before, we used to classify hormone receptor positive, HER2 positive disease overexpressed, and the triple negative breast cancer. However, lately, in the era of the personalized medicine, we are using several biomarkers such as the PD-L1 testing, the PIK3 kinase, the HER2 low, ESR1 mutation, TROP2 as well. However, today I'm going to focus about the germline BRCA in hormone receptor positive. Well, in early breast cancer, the adjuvant treatment, we all know, I'm just going to review this quickly. In ER positive and HER2 negative, the standard of care is giving chemo and endocrine therapy based on prognostic and genomic factors that has been discussed beautifully in the first session. HER2 positive disease, we give chemotherapy plus the anti-HER2 therapy and endocrine therapy in case of ER positive disease. However, in triple negative, we give, and as adjuvant setting, the IO, capecitabine, and PARP inhibitors. Well, these tumors, basically, digging deep inside, represent, some of them, they have this BRCA1 and BRCA2 mutation. The FDA approved the olaparib in the adjuvant setting for early breast cancer in high-risk patients that I will detail later on. Our decision on the type of adjuvant treatment are based on three core factors. First, the predicted sensitivity to particular treatment types, the receptor status, determine whether the patient are eligible for hormone therapy, the germline BRCA mutant status that described beautifully by Dr. Gerli, and individual risk of relapse. It means like prognostic factors for risk of recurrence, including the lymph node involvement, tumor size, histological grade, presence of estrogen receptor, not achieving a PCR, especially in neoadjuvant therapy, recurrence score, and Ki-67 score. And as well, the benefit versus the risk of use of adjuvant setting, risk of relapse, sensitivity to particular treatments, affect the benefit and the risk ratio of treatment, impacting the quality of life, as well as very important factors like the age, general health status, comorbidities, and patient preference should be also taken into consideration. Well, detection of a germline BRCA mutant significantly impact the patient care plan. Patient with germline BRCA mutation often younger and present with aggressive disease. In germline BRCA are alter surgical decision and therapeutic option that will be discussed later, the prophylactic mastectomy. Olympia trial investigates the olaparib as an adjuvant therapy for patients with germline BRCA HER2 negative early breast cancer who have higher risk of recurrence despite the standard of care, local and systemic therapy. What's the rationale for Olympia trial? The Olympia trial aimed to target this patient population specifically and explore the benefit of olaparib versus placebo as adjuvant treatment in patients with germline BRCA HER2 negative high risk early breast cancer. The value of olaparib in breast cancer has already been successfully shown in metastatic breast cancer in Olympiad trial. That's why we're trying to we use this molecule in early setting as adjuvant treatment. And the Olympia trial aimed to target the patient population specifically and explore the benefit of olaparib versus placebo as adjuvant treatment. Olaparib is a PARP inhibitor that target tumor with DNA damage response deficiency. Who are the patients at risk? So I'm going to discuss three trials. Okay. The Olympia, the use of CPC and EG score includes several different clinical factors. Well, this is the MD Anderson algorithm. We can see here. Can you just? Thank you. We can see in this table the clinical stage as a pre-treatment, as a staging, the pathological stage which is important, the post-treatment, the receptor status, and the nuclear grade. However, in Olympia trial, the scoring system, if reached or been more than 3, they were eligible for the Olympia, for the olaparib group. However, there is another trial. This is not really, they defined the high risk, clinical high risk in the MINDACT trial, defined as grade 1, tumor more than 3 centimeter and 0, grade 2 from CT2 and to 0 to 1, and grade 3 tumor or CT1C to 2 and 0 to 1. However, in Monarch E, the high risk disease characteristic, what are they? So just to make it simple, it's a lymph node 4 than lymph node positive patient, or in 1 to 3 lymph node and at least one of the below. The tumor size more than 5 centimeter, grade 3, and Ki-67 of 20%. Olaparib in early breast cancer, the Olympia, how does it work? Well, I'll go through this very simple way. We do have all the double-strand DNA. Okay, and it has the capacity to autocorrect any scars when it happens to itself. However, when there is any scar, a scar in the genomic DNA, okay, that can cause a small molecule or protein named the PARP to accumulate at that site. Okay, accumulation at that site, if we inhibit these proteins, the rescue protein, we will cause the DNA replication fork and lead a double standard break and cell death. Olympia phase 3 trial of olaparib versus placebo as adjuvant treatment for high-risk germline BRCA mutant and HER2 negative breast cancer. This trial has been discussed elegantly previously, so we'll go through it very quickly. They include the germline BRCA1 and BRCA2, stage 2 to 3, high risk, as I described before. They used the MD Anderson score, and the neoadjuvant, they were allowed in triple negative and non-PCR and HER2 positive non-PCR and CPS plus EG score plus the 3. As well as the adjuvant group in triple negative breast cancer with PT2 or N1, HER2 hormone receptor positive with more than 4 lymph nodes. They were randomized between the olaparib versus placebo, and the primary endpoint was invasive disease-free survival and distant disease-free survival and overall survival. They used a multiple procedure was adopted, ID invasive disease-free survival, and the second interim analysis was the overall survival. However, what are the baseline characteristics were well balanced between the treatment group. We can see here like 70% of the patient were BRCA mutant, and 30% of the patient were BRCA2. Most of the patients were premenopausal, about 62%, which represent our population, and in postmenopausal states, about 40%. The majority of patients have higher grade tumor, that we can see it here clearly in this table. The pathological characteristic and the CpG and EG score by the hormone receptor status. In the neoadjuvant, first of all, we can see about 86% were of higher risk by using the score they used in this trial, and hormone receptor HER2 negative about 90%, and triple negative breast cancer represented about 40%. What's the results? We can see beautifully here the olaparib reduced the risk of invasive disease recurrence by 42% versus placebo in intention to treat population with a hazard ratio 0.85 with a significant p-value, and 3 years invasive disease-free survival was about 86% versus the placebo. However, the 1 year additional follow-up, it shows again a hazard ratio of 0.6 with a 4 years invasive disease survival rate of the olaparib about 83% versus 75% of the placebo arm. And again, the 3 years free survival, over 7% or more patients treated with adjuvant olaparib were free of distant recurrence or death at 3 years versus placebo with a hazard ratio of 0.56 with a significant p-value. It's around 87%. Longer follow-up also confirmed that at 5 years, with a hazard ratio of 0.6 and a 5 year distant disease-free survival about 87% versus 80% in the placebo arm. Olaparib demonstrated a significant overall survival benefit with 90% of patients alive at 5 years in the olaparib arm. And this confirms with a hazard ratio about 0.86 with a significant p-value and a 4 years overall survival rate about in the olaparib group about 90% versus 87%. This was consistent benefit was seen across all invasive disease-free survival subgroup. As you can see here, all were in favor of the olaparib. As well, overall survival benefit is derived across all subgroups. What are the adverse effects? Adverse effect, the most commonly that we see is nausea and anemia. Anemia is the only grade 3 adverse occurring in more than 5% of the patient, but usually we don't need to interfere with these abnormality, and usually patients tolerate very well. The Olympia conclusion trial is the first to report the clinical benefit of a PARP inhibitors as adjuvant treatment in patients with germline BRCA mutant, HER2-negative, high-risk early breast cancer, with a 9% more patient recurrence-free at 3 years. 1 year's adjuvant olaparib significantly reduced the risk of recurrence death by 42%. Adjuvant olaparib resulted in patients living longer with a 32% reduction in risk of death, consistent with the previous studies. Safety profile and manageable and test of germline BRCA at diagnosis is important to inform the treatment decision and maximizing long-term outcome. So what are the challenges in introducing olaparib in early breast cancer? What about the use of capecitabine and adjuvant setting? Should it be fit for all stage? The optimal duration is 1 year is the optimal duration. Can shorter duration be used? We don't have the data for this. What about the abemaciclib for adjuvant in hormone receptor positive and BRCA1 and 2? What about other germline mutation or somatic mutation? We'll just briefly, this is again, just to highlight, this is in a metastatic setting. It's a phase 2, a study of olaparib for metastatic breast cancer mutation in homologous recombination related gene. Again, it's a basket trial. These are the, it's a cohort study. The first cohort was a germline mutation, and the cohort 2, if it was allowed, if the germline mutation was not there, tumor assessment every 6 weeks, and we gave olaparib 300 milligram BID Q21 days. In this graph, the swimmer plot shows the green germline cohort best response, has the best response. And we can see in green the PALB2, ATM, CHEK2, and other. However, in somatic cohort, again, in this trial is we have a very small number of patients. We can see in the swimmer plot, we can find the BRCA1 and BRCA2 as well, and as a somatic mutation with some response. Also in PALB2. What about the guidelines? The latest guideline this month, okay, showed that in hormone receptor positive, HER2 negative, adjuvant olaparib in germline BRCA1 or 2 mutation with a CPS-EG score more than 3 and residual disease selected may be eligible for olaparib, and also we can discuss abemaciclib as well. However, in HER2 negative disease, adjuvant olaparib for 1 year in germline BRCA1 mutation. In conclusion, BRCA mutation is often diagnosed at a younger age and have more aggressive disease, higher grade, increased nodal involvement, increased mitotic indices, or higher recurrence score. Adjuvant olaparib is the standard of care in patients with germline BRCA mutation. Somatic BRCA and other germline mutations such as PALB2 appear to respond in similar fashion, but more trials need to be done. With that, I conclude. Thank you so much.
So, thank you very much, Dr. Sadel, to sticking to time. It's a pleasure to introduce our next talk speaker. He's in the US, coming to us through the virtual. He's Dr. Mohran Galsha. He's a Deputy Chief Medical Officer of the Surgical Service at Yale Cancer Center. He's a very well-known figure in breast surgery. He's one of the board members of the National Accreditation Program for Breast Cancer. He led many trials and he's part of many important publications in breast surgery. He's one of the best educators in breast cancer surgery. Dr. Mehra, can you please start? Thank you very much.
Thank you very much for the kind introduction. Good afternoon or good early evening in Riyadh. I wish I was there in person with you, and I was planning on coming. Unfortunately, wasn't able to, but really excited to be here. I just need them to allow me to share my screen. Can you hear me?
Dr. Mehra, we can't hear you. So if you can just give us a few minutes to try to connect
How about now?
Can you start now?
Can you hear me now? I need to be able to share my screen.
Please go ahead now.
I need to share my screen. You have to let me, it's disabled. Would you allow me to share with a screen, please?
It is enabled now.
Okay, thank you so much for the kind introduction. I wish I was there in person with you. Inshallah, next time we'll be in person in Riyadh. I would like to thank the organizers for this wonderful opportunity to present on breast reconstruction and challenges for the multidisciplinary team. I've had the pleasure of working with many of you in the Kingdom of Saudi Arabia and the surrounding countries, and the work that you do is absolutely fantastic. It's an honor and a privilege for me to be here today. So I thought I would spend a little bit of time talking about some of the general approaches to breast reconstruction for high-risk patients, whether they're hereditary mutation carriers, those, for example, who've had mantle radiation, and what are the reconstruction options that are available to the patient, who is considered at high risk, what are some of the guidelines and recommendations, and some of the trends and outcomes that we see. So the most important thing I would say as we start off is that it is multidisciplinary management. It's just not me, the surgeon, who dictates things. We work very closely with our counterparts in medical oncology, radiation oncology, reconstruction surgery, breast pathology, breast imaging, and it's very complex in terms of the decision-making on which modality to use and the role of each discipline. Many of the centers in the Kingdom of Saudi Arabia and the United States, we have these multidisciplinary conferences, and I think the importance of these is that it's open communication with our colleagues and really consideration of the patient's disease process. What are the patient's goals and expectations and lifestyle? And what are really the expected outcomes to be? And then the sequence of interventions. Should you do immediate reconstruction? Should it be delayed? There are some women where no reconstruction is the best option, at least up front, and maybe considered down the road. Or there are women, maybe, for example, with widespread, metastatic disease where reconstruction shouldn't be at the front and center on the table. The goal for the surgeon and the plastic surgeon, our number one goal, with just like with my colleagues in medical and oncology, radiation oncology, is the optimal treatment of the cancer. But then the secondary goal is to create a breast mound that is soft. I call them the 4 S's: the soft, symmetric, sensate, or scarless, or at least to do our best to hide the scars. And that's the challenge, is when you're balancing an oncologic procedure with reconstruction. Yet the limitations for us as both breast surgical oncologists and reconstructive surgeons is that the number one goal is the optimal treatment of cancer. And in many cases, those that present with more advanced disease, we certainly see that in the Kingdom of Saudi Arabia, where more patients will present with stage 3 or 4 disease, that they're going to likely get radiation afterwards. Many will get neoadjuvant therapy or adjuvant afterwards. So you have to take into patient preference and lifestyle, the comorbidities, what are the donor sites that are available, have they had previous operations? And then there are limitations to the size and shapes of the implants. There are concerns with implant-associated lymphomas, and some more recently, some more kind of squamous cell type carcinomas associated with implant utilization. And those are concerns, very valid ones for our patients. A lot of this is from the United States data, but certainly some of it and much of it is applicable to other countries as well, is that many patients in the United States are not even offered reconstruction, even though in the United States, insurance pays for immediate reconstruction, delayed reconstruction, reconstruction on both sides, or even doing what's called contralateral symmetric surgery on the opposite side. The majority of this is implant-based reconstruction in the United States. Autologous is a smaller portion, about 30%, but the use of microsurgery, perforator flaps in that group has increased quite a bit. At my previous institution, Farber in Boston, and even at Yale Cancer Center, over 80% and 90% here at Yale will undergo immediate reconstruction, but there is wide variation based on where the patient is geographically, patient's age. We know that those, for example, over the age of 70 have more likely to have adverse outcomes, comorbidities, the economic status, and honestly, the lack of referral to reconstruction. The timing of reconstruction, very important. Patient preference, comorbidities associated with them. If you're going to use post-mastectomy radiation, what are the challenges? And if you're going to do chemotherapy with neoadjuvant or even adjuvant therapy, if you have open wounds, you need those to heal up before you're able to restart or start any form of adjuvant therapy. And some of the newer targeted agents, we don't have a lot of data in terms of its safety and efficacy in terms of wound healing and recovery associated with surgery. A study I did a long time ago when there was bevacizumab, what had been rapidly approved by the FDA for consideration for triple negative breast cancer. We know that that ended up not being efficacious. We looked at our complications rate associated with the angiogenesis inhibitors and higher rates of necrosis of our flap. So those are really important things to consider. Once you decide your patient with a hereditary mutation or mantle radiation in the past is able to undergo reconstruction, then I really break it down into expander implants, whether you can use acellular dermal matrix or some kind of scaffolding or platform to recreate the inframammary groove, or autologous reconstruction in the tram, the deep, the S-gap, and the tug. We know that reconstruction patients in the United States overall were younger. In a NISQIP study, this is a American College of Surgeons data set looking at complication rates associated with different types of surgical procedures, and in this case, reconstruction, and that factors that led to complications were older age, higher BMI, diabetes, smoking, especially active smoking, COPD, hypertension, and higher body mass index. And really, as the amount of operative time increased, the complications also increased, and that there was a higher rate of complications for when you compared flap to implant reconstruction. A large cohort study that was done in the state of Michigan showed higher complications in the immediate versus delayed reconstruction, and that things such as BMI led to higher complication rates. We know that the use of radiotherapy is a challenge. Reconstruction makes it challenging for the radiation oncologist to target appropriate radiation, but also radiation makes it a challenge for the type of reconstruction that is used, and potentially higher failure rates. For example, those that had prior radiation or that get post-mastectomy radiation had higher rates of, especially in the implant group, of complications in terms of failure of the reconstruction or capsular contracture. So the factors that they saw in the Swedish multi-cohort study was higher BMI again, inexperience of the surgeon, and certainly post-operative infection leading to higher failure rates. A large nationwide inpatient sample data study over a 12-year period of time, comparing very low volume centers to those that, for example, who do quite a bit of breast reconstruction, like our center here. And when you adjust it for many of the variables such as age, comorbidities, obesity, that the lower volume centers had higher complication rates than high volume centers. And that's something that needs to be taken into account to the patient population. This preoperative or neoadjuvant therapy was a particular interest of mine. We had done a study, again, early on, this is when bevacizumab was being used in the neoadjuvant setting for breast cancer. And we actually saw a very high complication rate overall, and that there was actually a numerically higher rate of implant failure with the bevacizumab group but that actually did not reach statistical significance. But we really wanted to emphasize the importance of the surgical team knowing what our medical oncology team was giving in the neoadjuvant setting, and then the timing, meaning like the half-life of these drugs, making sure that the patient's counts have recovered before undergoing complex breast surgery with reconstruction. Some of the other institutions that do high rates of breast reconstruction with those that undergo either neoadjuvant therapy or at high risk of getting post-mastectomy radiation, and the increased use of nipple-sparing mastectomy shows that, again, even in expert hands, that there is high rates of infection, nipple necrosis, and mastectomy flap necrosis, but with increased experience, better patient selection, that complication rate does lower, but it never drops to zero. And that's something that really your patients and our patients all need to know what those numbers are and what the data shows. The Mass General group has which were my counterparts in Boston, have a high rate of use of implant reconstruction, not as much use of autologous reconstruction. And in the tissue expander group had higher rates of implant failure and complication compared to those that went direct to implant or the flap group. And there was a lower time to actually be able to give appropriate post-mastectomy radiation therapy when you go direct to implant, and you don't have to have the multiple succession of expansions. In the Yale experience, and Lahush Pushtai here and our reconstruction surgery colleagues have published on this as well. They showed that in the taxane group that there was, with the use of taxane, that there was increased complications, especially fat necrosis. The use of PMRT versus no PMRT, the complication rates were roughly similar, but there was more fibrosis after the use of PMRT, and there were more multiple complications, although when you take complication rates overall, it was no difference between those groups. So those are things, again, that you need to take into account. With the implant expander operation, if you're going to go to expanders, you're going to have multiple, you're going to have more than one procedure in terms of surgically. You're going to have to come in for expansions, but it is a shorter operation compared to a flap reconstruction. You don't use your other tissues, so you can always fall back and salvage on those. There's minimal scars when you go, like, for example, with a nipple-sparing mastectomy with an immediate implant reconstruction. However, radiation is a challenge in this group with capsular contracture. And certainly there is thoughts in terms of you need to follow these patients for maintenance surgery, leakage, rupture, and the rare associations of these malignancies associated with the implant utilization. In the United States and many parts of the world, if you just put an implant straight in, there is no natural projection of the breast. So using the inframammary fold afterwards with scaffolding with acellular dermal matrix is something that's important to utilize. It minimizes the muscle dissection, helps manage maximize the amount of natural breast skin that's available. And this is either both for use on the subpectoral, and then there's a lot of work being done on prepectoral implant utilization as well. Latissimus flap, we're not utilizing as much. It's much more of a salvage operation. It's a longer operation. The size of the latissimus is usually not large enough by itself to recreate the breast mound adequately in terms of size. So often it still needs an implant. And but if you could put some natural tissue and muscle over the implant, it does decrease the use of decrease some of the challenges associated with radiation. But you have to worry, especially for your active patients, that the loss of muscle function with shoulder weakness, and then there needs to be some synergistic compensation of the surrounding musculature. And I would not use this in our active swimmers, tennis players, golf players, skiers. In terms of autologous reconstruction, there's the abdominal procedures, traditionally in a pedicle fashion, then in the free trim, and then more recently over the last decade with the perforator flap concept. There are gluteal reconstruction, which again tends to be in a very limited population. It's a very technically complex operation, often has to be done in 2 different settings. With a pedicle tram, the benefits are, especially for patients who are cautious or wary about wanting to use a foreign body, you're using all your own natural tissues. It does look natural, and it also ages with the patient, but you do sacrifice the entire rectus. There is abdominal weakness, abdominal hernia formation risk, and fat necrosis. There are some biomechanical compensations associated with this, but it is never perfect afterwards. The free tram really kind of came after the pedicle tram. There's no implants, a very natural looking result. There is less fat necrosis because you actually have a better blood supply, but you'd also still go back to sacrificing the rectus muscle. There's abdominal weakness, risk of hernia, and then the challenges of microsurgery. The perforator flap concept, and that's our preferred reconstruction if you're not undergoing implant reconstruction, using the skin and the fat, but preserving the muscle in place, and helps minimize the donor site morbidity. There are cost implications because this is a longer operation, longer duration of anesthesia, often the need for 2 reconstructive surgeons to work together. So those need to be taken into account, but it is ideal for these mutation high-risk patients because the flap will age with them. There's no implant associated risk. It is very good for our active patients. And they are often are the ones that are able to tolerate the longer operations associated with this. The nice thing is that obesity is not a contraindication to this procedure, but I do think that there are, risks associated when you're doing a perforator flap procedure. And if you're going to get radiation, I think the safest, if they've had it in the immediate past and you're doing this delayed, is to wait at least 6 months for those effects to go away. You should, be cognizant of the risk associated with autoimmune disease, especially with active treatment, diabetes, the type 1, and then the previous donor sites, whether it's cardiac surgery and potentially using the internal mammary, or where if patients have had previous laparoscopic type procedures, the port placement sites, and again, smoking, I would say absolute contraindication to these types of procedures, especially if they're also at high risk of having either previous clots that have been treated with anticoagulation therapy. The nice thing, though, is, again, no implant, very natural looking. It ages with the patient, minimal abdominal weakness, minimal risk of abdominal hernia formation, but it is a technically challenging operation. You want expertise hands with this, and it's a longer operation. The superior gluteal flap, we don't utilize as much anymore. But again, no implants, very natural looking results. If you don't want to have the risk of abdominal complications or scarring, it is a procedure to consider, but it is a technically difficult operation. We do not do them in bilateral settings. The tug flap, again, we don't utilize as commonly anymore. It really depends on if there's no abdominal muscle availability, you're able to get a no implant natural looking result that ages with the patients, but it is a technically difficult operation. And then there's the skin paddle formation. So back to my early days in the Kingdom of Saudi Arabia. So how do we narrow this down? This is from Al Faisaliah looking over to the Kingdom Tower. Important factors, again, cancer management, the use of post-mastectomy radiation, chemotherapy, the medical history and patient preferences. If you've had radiotherapy, autologous is the gold standard. There's healthy, well-perfused tissue that's put in there, and expanders and implants have high risk of complications like capsular contracture, infection, erosion, and asymmetry, and those absolutely need to be discussed with the patient. If you have planned post-mastectomy radiation, the safest option for the patient is to wait at least 6 months after the completion of radiation and do a complete delay. You could consider an expander placement followed by delayed autologous, or in some cases, expander formation or implant, and then go through the radiation and then see what happens down the road. I always, again, talk to our patients about, and our medical oncology colleagues about neoadjuvant chemotherapy. They're more likely to have a more advanced disease and the use of post-mastectomy radiation therapy. So really want to make sure that you understand the biologic agents that are being used and the anti-chemotherapeutic agents and the complications that may be associated with those. Taking into patient preference into account, if they want a minimal operation, shorter recovery, shorter surgery, implant. If you don't want much scarring to the rest of the body, implant or an expander. If you don't want muscle move, implant or perforator flap reconstruction. No implant, and the most natural type is autologous. If you want autologous with no microsurgery risk, that is the pedicle tram. If it's autologous with morbid or obesity or high BMI, the deep or the free tram. Autologous with preserving the abdominal muscles is the deep. Autologous with minimal hernia formation, you should do deep. And if you don't want to use the abdominal tissue, but still autologous, the S-gap or tug flap. So really multidisciplinary care, talk to the team, listen to your patients. There is one more part to this talk, and this is, again, really US kind of centric in terms of how many women are undergoing mastectomies in the United States and contralateral prophylactic mastectomy, even if there is no hereditary predisposition to breast and ovarian cancer. I was interviewed a long time ago by Time Magazine, and some of our research that was published in terms of why women were undergoing double mastectomy, even if there is no hereditary predisposition. Certainly, in the US and many parts of the world, we talk about the Angelina Jolie effect. So in Annals of Surgery, one of my previous fellows, both research and clinically, Dr. Stephanie Wong, who's now in McGill in Canada, we looked at the growing use of contralateral prophylactic mastectomy in the United States, really no effects on overall breast cancer survival. So what we wanted to do was look at national temporal trends in the use of contralateral prophylactic mastectomy and whether there was any difference for these patients with invasive breast cancer based on hormonal receptor status. This is how we came up with our final analytical cohort of nearly 500,000 patients, and comparing those who underwent either breast conservation, unilateral mastectomy, or contralateral prophylactic mastectomy. So of those 500,000 patients, fortunately, 60% underwent breast conservation, 33% underwent unilateral mastectomy. But during this trend, and this was even prior to Angelina Jolie coming up with her, declaration to the public of what she went into, our contralateral prophylactic mastectomy rate was just 7%. But what you'll see is the trend over time is that breast conservation really stayed the same. Our unilateral mastectomy rates went down, yet our contralateral prophylactic mastectomies nearly tripled during the 10 years of that study. And if you remember, Angelina Jolie's discussion on this didn't come out until 2013, 2012. So even before that, we showed a tripling of contralateral prophylactic mastectomy in the United States. We saw this across many age groups, depending on the age of the patient. Yes, we saw it higher amongst younger patients, but we also saw those with more advanced age. We saw it across the different demographic and geographic patterns that we see in the United States. Again, fascinating area of study. And then despite more aggressive surgery, contralateral prophylactic mastectomy did not improve overall outcome or survival when you adjusted for things like stage of patient, age of patient, and hormone receptor status. So we showed that CPM increased during the study, and even though that more extensive surgery did not improve survival for those with a unilateral breast cancer diagnosis, this is something that we are seeing more and more of in the United States. So with that, I'd like to thank you for the privilege of the podium. I'd like to thank my dear friend, Professor Nafisa Abdel-Hafez, for the kind invitation to present. And it's an honor to be amongst so many esteemed people here. So thank you so much.
Thank you, Dr. Mahara, for excellent comprehensive presentation. Now we'll move to the next presentation, which will be presented with which will be presented by Prof. Thomas Herzog. Prof. Thomas Herzog, he is a professor from University of Cincinnati. He is well-known gynecologist, oncologist. He is also the deputy director of the University of Cincinnati Cancer Center. Dr. Thomas will be presenting to us the BRCA career, prophylactic salpingioophorectomy, clinical management, and consideration recommendation. Dr. Thomas, floor is yours.
Dr. Thomas, can you hear us?
Is he connected?
Would you like me to start?
Yes, please.
Okay, thank you. So I have an FDA audit going at the same time, so it's a busy morning here. So thank you for having me. Share screen here. I'm having trouble sharing the screen here. Do you have the presentation up?
Yes, we do.
Okay, thank you. Okay, can we go to full screen on that then? Great. Okay, thank you. And I don't believe I'll be able to control it, right?
No, only from here.
Okay, next slide. Well, it's a pleasure to be here with you. I wish I were in Riyadh, but unfortunately I'm not. I'm here getting an FDA audit today and being in the OR. So it's been a hectic morning. I'm going to do everything I can here to get through this as quickly as possible. You see my disclosures there. Next slide. Next. So we're going to talk a little bit about BRCA mutations and how they impact clinical care, especially thinking about ovarian cancer from the perspective there. I know this is a conference on breast cancer, but we're going to think about what do you do with the ovaries in these circumstances. But we also have prostate and pancreatic cancer that also increases. Next slide. So here you see ovarian cancer, and I think everyone's familiar with the fact that most of these patients unfortunately present with stage 3 and 4 disease, and you can see the dismal 5-year survival that's present in all those particular areas there. And I think that that's a big issue that we have. I think you know, we need to continue to do a better job of screening, especially in these patients that have BRCA, and it's really a challenge. Our current protocol is to do ultrasounds every 6 months and to do CA-125 levels on them, but whether that's really beneficial is yet to be proven. Next slide. So who should be tested for BRCA in those with ovarian cancer? In 2009, we moved away from what was commonly done with breast cancer, and we moved to universal testing because we found that family history and some of the other so-called red flags in terms of prior cancers within the family and so forth were not informative. So if you could hit the next thing there. So all the organizations, NCCN, the Society of Gynecologic Oncology, American Society of Clinical Oncology, have all recommended that we perform universal testing. If you could hit the next slide there, it'll come up. Thank you. And then next slide. So we're going to move into looking at breast and ovarian cancer, and I've got a lot of slides here. So if we could just sort of move through these. Next. Okay, so this is a pie. Okay, that's fine. We're going to we'll really get moving here then. So we skipped over the breast. That's fine, and that was the ovarian pie chart there. And this is looking at the two BRCA1, BRCA2 tumor suppressor genes on chromosome 17 and 13 respectively, and we all know this information already. Next. Again, looking at the chromosomes that are present, just to sort of level set where we are. Next. So these are the risk of developing the cancers. And so if you have a BRCA mutation, your chances of getting ovarian cancer are really quite high. They're over 50% during the lifetime. BRCA2 probably up to about 30%. And so we also see some other syndromes there that are interesting, but we do know that there's an increase in fallopian tube cancers as well. Next. What I wanted to show you here is that you need to think about the time of onset, and this becomes important in terms of clinical management. So somebody comes to you with breast cancer, for example, that gets treated, and now they find out that they have a BRCA mutation. Well, it matters a little bit if they're BRCA1 or BRCA2, right? Because if they're BRCA2, you can delay prophylactic BSO and allow them to have a child. And so it makes a big difference in terms of management. Next slide. You can see here the risk by age, and I think this gives you some insights as to how you manage the patient based on BRCA1 versus a BRCA2 mutation. So, you know, as you get into late reproductive years where it starts to matter, you know, into the, say, early 40s, which, believe it or not, we have many patients in our country now who work until they're mid to late 30s, then get married and want to talk about having children in very late 30s and early 40s. You can see that jump there. So BRCA1, probably a tough decision to make. BRCA2, you can do that with a little more confidence, although there is always still a risk. Next. These are the features of the BRCA-associated cancers. I'm sure you're well aware of the likelihood for ER/PR more with BRCA2 than 1 in terms of breast cancer. In ovarian cancer, they're predominantly papillary serous cancers. Next. And then this is looking at the carrier rate of the genes here in our country, and they vary by nationality. And I was going to put some of the data in that we just did a global heat map. As I encourage you to look at that paper. It just came out. It's with Brittany Hughes as the primary author and myself as the senior author. We did a heat map of the entire globe, including Saudi Arabia, looking at some of the screening behaviors for BRCA and the prevalence and so forth. So interesting data there. Next. So this is looking at risk reduction surgeries in hereditary breast ovarian cancer. And this is sort of the focus of what I wanted to talk about today. Next. So I think the first thing is who should consider risk reduction strategies. And obviously those women with BRCA1 or 2 mutations. Occasionally we'll have someone that just has such an overwhelming family history that we would consider that because there's clearly something going on in terms of some epigenetic effect or some genes that we're not understanding their interaction. Could be RAD51C. You have to start looking for other genes such as PALB2, BRIP1, those types of genes that can contribute as well. Next. And so these are the strategies that you can use if you find someone has a BRCA mutation. So obviously you change the screening. You can do chemoprevention, as you see with breast cancer, but we can do birth control pills and those types of things with ovarian cancer to reduce the risk. And then, of course, risk reduction surgery. So those are key in terms of looking at that. Next. And here you can see the impact of OCPs. It significantly decreases the risk of developing ovarian cancer, even in those with BRCA1 mutations. Next. Tubal ligation has been shown to decrease the risk, and you can see the numbers are smaller in the BRCA2 cohort. That's why it's probably not significant there. But in BRCA1, where we had a much larger number, risk overall, the risk reduction went down significantly, or it was significant. Right, next. This is looking at the data from risk-reducing Salping oophorectomy, which clearly decreases the risk of developing ovarian cancer. As we've learned the techniques, it's now under 0.1, so you're going to have probably a 95+% reduction in the risk. Remember, they can still develop primary peritoneal cancer, or occasionally there could be an ovarian remnant that's left behind. So it's so important to do the surgery properly. But you can also see the reduction in the risk of breast cancer upon doing a risk reduction oophorectomy in those who are premenopausal. So Noah Koff, the Rebic, and Domchek papers all showed really large hazard ratios favoring a significant reduction in the risk of breast cancer. Next. These are the Kaplan-Meier curves that show the estimates of time to breast cancer for those that had risk reduction surgery versus those who did not. Very clear difference in the outcomes there. Next. It's important, I'm going to dwell on this, but it's important to understand that when you do a risk reduction surgery, there's several things that need to be taken into account and need to go into patient counseling. And I think that that's really key, is the patient counseling part of this is important. So the patient needs to be counseled that there could be actually cancer already there that was subclinical. And so they should be consented for potential staging and that type of thing if it's discovered. And the pathologist needs to be intimately involved in this as well. Serial sectioning is very important. Biopsy of suspicious areas. So, and assuring an adequate margin along the infundibular pelvic ligament. So it's important to open up the sidewall and go back on the infundibular pelvic ligament, the blood supply to the ovaries, to get a proper margin so you don't have an ovarian remnant that's present. And so some people I know clamp right along the ovary and can leave some microscopic ovary or even gross ovary that's present, which could become problematic. Next. So you want to make sure that the proper margins, as I said, do peritoneal cytology. Some people, that's questionable. Some people do it, some people don't. But that micro sectioning with 2 to 3 millimeters across your fallopian tubes and your ovaries is critically important to make sure you don't miss an occult cancer. And so I think that that's very important that that's done, and that you communicate with your pathologist, because if they just do the normal protocol, they'll take a couple biopsies from the ovary and say everything looks fine. So you have to make sure that they get the serial sectioning. Next. Again, getting that adequate margin. This is showing a stapler, which we don't any longer do that. We have energy devices that do this minimally invasively. Next. And this is just showing doing it grossly, making sure we're far away, you know, at least several centimeters away from the gross ovary there. Next. Next. You want to take as much fallopian tube. Question, I think, is sometimes, do you need to take the uterus? Most of the cancers that arise from the fallopian tube, we believe, are in the distal end. So as long as you're getting, you know, 80+%, 90% of the tube, you're probably in very good shape. There have been very few, if any, reports of any cancers that have arisen in the interstitial portion of the tube. But there is an increased risk of papillary serous cancer of the uterus. That risk is small and usually presents early. So some people, there are a couple centers in this country that recommend removal of the uterus. Most centers do not, but the patient do need to be counseled about any postmenopausal bleeding as usual to get immediate evaluation. Next. And this is looking at the prevalence of the occult cancers. And you can see some of these are pretty high, oddly high. The usual rate that we quote is somewhere around today with better imaging and so forth. It's usually 2% or less. Next. So complications of risk reduction surgery with removing the bilateral salpingo-oophorectomy, taking out both tubes and ovaries, is bleeding, adhesions, bowel obstructions. All these are very low in experienced hands. If the patients had prior surgery, this could obviously be a problem, but otherwise it's not much of a problem. Premature menopause can occur. There can be problems with that, obviously, and the problems that come with that, including osteoporosis, vaginal atrophy, and even coronary artery disease need to be considered. Next. So this is the question about the hysterectomy that I already addressed. If the patient has a history of being on tamoxifen, then that makes it a little more compelling to consider doing a hysterectomy, but the patient could still be spared a hysterectomy. You might say, well, why not do the hysterectomy? In most patients, the problem is that you will then make this outpatient procedure into an inpatient procedure with greater recovery time, greater cost. And as I said, they'll probably be in the hospital for one night, although you can send these patients home the same day as well. But many patients are in too much discomfort to go home the same day. So those are all issues. Next. Cons of removing, as I said, are the hospitalization, complications, cost, and so forth. Next. Timing of the procedure, we already talked about. Much lower risk of developing ovarian cancer. We BRCA1 patients as soon as they're done having children. And if they're still have not had children in their late 30s, I tell them that they're starting to get into the beginning of the rise of the curve. And so they need to be thinking about that. So very often I'll be more aggressive in counseling a patient with BRCA1 versus BRCA2. But you have to remember that the risk is not zero in either of these patient cohorts. So if a patient's very risk adverse, they need to have them out earlier than later. But in general, you can be a little more conservative with the BRCA2 group. Next. Hormone replacement therapy, it's usually the issue of whether they have developed breast cancer or not, and what that showed, and working with the medical oncologist as to whether they are comfortable with receiving hormone therapy. In terms of the ovarian cancer itself, no, we don't have a problem with doing replacement, and we have data to support that. Next. So risk reduction surgery, lots that we have to consider in terms of we mentioned all these, I think, so in the interest of time, let's just move on here. Next. So one of the things I wanted to talk to you about this afternoon for you is this idea of opportunistic salpingectomy. And this may be something, remember that we believe that most of the ovarian cancers actually start in the distal end of the fallopian tube. And so this is an opportunity if the patient wanted to remain hormonally intact and get her ovaries out at a later time, maybe 5, 10 years later or more, you could actually take out the fallopian tubes if she's done with childbearing. And so a number of things have been looked at in this, and this is looking at, this came out from the American College of Obstetrics and Gynecology in 2019, looking at the literature, and it's a good resource if you want to look this over. I'm going to show you some other data as well. I've been involved in this pretty closely. Next. So this is the, talking about the removal of the tube, as I said. In most cases, the ovarian function is not affected and you're able to preserve ovarian function, but you have to be careful in terms of making sure that you don't do anything to interrupt the blood vessels to the ovaries. So you have to be precise in where you remove the tubes. Next. Of course, it's a counseling issue and understanding that the ovaries are not going to be removed and they would need subsequent surgery for those that are BRCA carriers. There's larger studies that are being done in Europe as well as in the United States, and we should have some data on those. And we'll be seeing more data come out. But in some of the modeling studies we've done, it looks very promising. I think overall, in terms of thinking about using this idea of opportunistic salpingectomy. Next. Next. So this is looking at one of the papers that I did. I'm second author there on this paper, but this was looking at non-GYN procedures. And so we looked at whether you could do this either during cholecystectomy, colectomy, and other procedures where you're in there, and we did modeling. Next slide. And this is this opportunistic salpingectomy, again, looking at this in terms of cost savings. And you could see this in the United States would probably save the healthcare system $626 million per year and would save a significant number of lives. Next. This is another one we did looking at insurance coverage for this in terms of what it would do, and a modeling that was different. And I'm the senior author on this paper. It just came out a couple of years ago. Next. This is looking at risk reduction of doing the salpingectomy. And you can see hysterectomy and so forth here versus you can see that the relative risk improvement is very significant. Obviously not as great as doing a BSO, but much better than doing tubal ligation. Next. And so our conclusions again here were we would save nearly 2,000 deaths per year from ovarian cancer in just our country, and significant money savings as well. So I think it's interesting data. Next. And then this is a paper that came out looking at doing this at the time of C-section, and one of my former partners at Columbia in New York, Jason Wright, where I was beforehand, was an author on this paper. Next. And again, they went through the number of deaths that would be saved and so forth, and it's significant. So, the performance of bilateral salpingectomy among women going C-section increased from about 5% to 13% in the 3-year period they saw. So we're seeing an uptake in this procedure in the United States. Next. So these are my conclusions. Sorry, I went sort of fast because I know we were running a little bit behind, and I wanted to catch you up, but I'm happy to send you a copy of the slides if you reach out to me, and happy to inform anything. But my conclusions are that inherited cancers are common. Risk reduction strategies significantly reduce the risk of inherited cancer in those that are at risk. And I think we have 2 tools in our toolbox, one being a bilateral salpingo-oophorectomy with or without a hysterectomy, or just doing an opportunistic salpingectomy at the time of other surgery or as a primary surgery itself. So I think that that's sort of been a paradigm shift. Patients need to be aware that they are at risk and they'll take advantage of risk reduction surgeries. We need to be open about asking about family history, about screening for BRCA, because knowledge is power and we can prevent these cancers from forming in the first place. And so it's so important that we continue to talk to our patients about BRCA and about screening with family histories. Next slide. Next, Shukran Laka.
Thank you very much, Dr. Thomas. And now we'll start the question. Then is anyone of the audience have a question? Okay. Yeah.
Thanks for the speakers. My question to Dr. Mohammed Al-Qarni regarding the local Saudi guidelines for hereditary and genetic counseling. Now we are facing many cases with strong family history of cancer, and we are doing through this partnership program some just limited screening for say BRCA, but we end up with negative results. Now, what is the current pathway and guidelines that we have to follow? Because also this is not only for the patient and but also because the insurance companies now start working and they are refusing these tests because we don't have clear guidelines. So now if I have patient with strong family history of cancer with negative say BRCA and the usual test which we do, the limited test, how can we deal with these cases? Can we send them to your clinic, genetic counseling clinic? Do we have, clear pathway in this regard? Thank you.
Thank you, Dr. Ahmed. This is a very important question. So unfortunately, we don't have our own local national guideline for hereditary cancer syndrome in general. However, recently we adapted the NCCN guideline for the MENA region, and I think the guideline will come soon. So this will save us some sort of guideline to do the test and to also to have some agreement with the insurance companies. However, I think we should have our own guidelines that is matching our population and based on our data. Now, regarding the referral, I think also this is a challenge, and even at the largest tertiary cancer center, still there is continue to be a challenge with the limited number of genetic counselor and the cost of the test. And these are a large process. Once it's not about testing the cancer patient themselves. Once they identify someone with positive gene, the next step is the family testing and these things, and it has to be through a program process. So it goes, depends on what you practice, but for now we are covering only Ministry of National Guard patients. I do accept I have some collaboration with the King Khalid Eye Specialist Hospital because they are doing also genetic testing, and we see some patients from them have through certain agreement, but I don't think we have the capacity to expand beyond this.
More question for Dr. Mohammed. With regard the BRCA testing, as you mentioned, ovarian cancer, now all the newcomer, we test them. What's your recommendation for breast cancer? Do you test all the patient diagnosed with breast cancer, or you have a specific criteria for those patients who should have the test or not?
So thank you, Dr. Nashmiya. So if you go to the guidelines, there is a certain testing criteria. However, my personal feeling and what I do with my patient, I test all the patient because I think it's just a matter of time before it comes as a part of standard of care for this patient. And we know the limitation of the guidelines that we're going to miss a good percentage of patients with cancer. So my personal practice, I'm not advertising this, but for my patient, I have access to the test and I test all of them. However, if you are working in an institution, I think you might need to adhere to the guidelines.
And what's your experience from cancer control program with regarding how do those patients and their family receive the idea of testing and screening their family? Do they accept it, or you have some challenging with that?
So initially, when we started, we thought this is going to be an issue, but alhamdulillah, I don't see this is an issue. Actually, some patients, they are happy to share this information with their family, and I can count only few families who refuse to share the information, disclose it to the information. So I think they are educated, they are aware, they don't want other family member to pass through this experience. So they are open for testing and for counseling.
And one question for Dr. Thomas, with regard the risk-reducing surgery, just what I want to hear from your recommendation for those patients who refuse the surgical prophylactic procedure. So what we do for those patients, usually we just screen them with the CA-125 and ultrasound every 6 or 12 months. So my question is, for how long we do screen them? Is there any age specific that we should treat them as general population, or we have to screen them for life?
Yeah, you have to screen them almost for life. You know, I would think when you get into your 70s or something, you may want to consider slowing down screening. But there was a paper that just came out. The deck was getting quite large, and I think I only had 20 minutes or less, and I didn't want to add it, but it just came out, and it looks at the development of cancer after age 50. It just came out this month. And it shows that the rate still is quite high, the incident rate. So we think these cancers can occur young, which is true, which is another reason why we test universally for ovarian cancer with BRCA carriers. That rate continues to be very high, even after age 50, after age 60. And so I think that you need to screen these people for a long time. Hence, most of them choose to have surgery at some point.
Yeah. Okay, thank you.
Dr. Gurney, so you recommend gene testing for all of breast cancer patients, irrespective of age, and يعني
Thank you, Doctora. For the testing, the benefit of doing genetic testing is not only limited to the patient. So when we do the genetic testing, we are not looking, I know, for example, if I have 75-year-old woman, if she's having BRCA positive, for example, this may not affect really the preventative strategy for her. However, this has a very important value to the family. So I think the benefit is not only limited to the patient, to the family. So I think it's still, even for older age, it's feasible to do it, and I think the benefit is more for the family member as well.
Do we have national or how much the yield of finding positive patients if we just screen everybody? Camel percentage?
So we don't have the data for screening everybody. However, from our data that we presented last year, I think we did not limit ourselves to the NCCN guidelines. So basically, any young patient less than 40 we test, any patient with triple negative were tested, anyone with suspicious family history we tested. So we have 320 patients tested. The yield is 16%. So 16% of them we have a
But this is within the NCCN guideline. But I'm saying if you screen everybody.
Yeah, so you mean universal genetic testing? It has to be done. You know, we don't have this data yet.
Okay. My second question is for Dr. Sadel. In an adjuvant setting for high-risk patients with PRCA gene mutation, what would you give? Olaparib or abemaciclib?
Thank you, Dr. Alulwa, for your question. Well, basically, I would give olaparib, and why is that? Because we have overall survival data already mature. Okay. However, abemaciclib in non-BRCA mutant, I would propose it for high-risk patient in such a setting.
One more question with regard to olaparib and PARP inhibitor used. And you mentioned about the adverse event, the anemia, and the other symptoms. Do you have any specific guidelines or recommendation with the dose adjustment for those patients who have significant toxicity? I mean, like dose interruption or reduction?
Well, basically, what I do in my practice, I start the olaparib, okay, with a systematic anti-nausea effect, metoclopramide, okay. I instruct the patient because usually it starts at the beginning and it gets better, okay. So we have to educate our patient about the side effects. I see them after the initiation of treatment 1 month. And then just a regular follow-ups in the clinic.
Do we have any other question from the podium or the online? Okay, thank you very much. We end the day today. See you tomorrow, inshallah. Thank you very much. Okay, there is a satellite symposium. ايش انا صلينا.
Don't leave, Dr. Ahmed. Still, we have the session. Okay, so now we'll move to the last session, to satellite symposium. It's my pleasure to invite Dr. Sadr for the first session. She will talk about the advancing role of antibody drug conjugate in HER2 positive metastatic breast cancer. This is a satellite symposium by AstraZeneca. Dr. Sadr is a consultant medical oncologist at National Guard Hospital. Please, Dr. Sadr.
Not this one. This one. Not this one. Thank you, Dr. Muhammad, for the kind introduction. So these are my disclosure. Today, I'm going to talk about the HER2 positive breast cancer account for approximately 20% of all breast cancer. However, in our population, we have just kind of higher than these results. There are, I think, 2 published trials, and the rate is reach about 25. The HER2 family receptor has been implicated in pathogenesis of human cancers. HER2 is involved in regulation of cell growth, survival, and differentiation via initiation of multiple signal transduction pathway. The HER2 gene acts as oncogene cancer. HER2 positive breast cancer is a subtype associated with HER2 gene amplification and high expression in HER2 protein. It represents about 20% in all breast cancer subtypes. HER2 positive breast cancer are more aggressive than the HER2 negative tumor. However, the biology of the tumor has been changed since the introduction of the ADCs. Compared with the HER2 negative tumor, HER2 positive are larger, more likely to be node positive, higher grade compared to women with HER2 negative breast cancer. They're more likely to receive chemotherapy, especially in a tumor more than 2 centimeters, less likely to undergo breast preservation, and HER2 positive cells have higher than normal level of the transmembrane growth receptor factor. So these are the newer generation of the ADCs. The trastuzumab deruxtecan is a HER2 targeted ADC within 7 key attributes mentioned on your right side. The topoisomerase inhibitor payloads, which you can see it on drug linker in yellow. Drug potency, the payload based on the cell-free assay topoisomerase 1 mediated DNA assay. The payload with a short systemic half-life and high membrane permeable, which may enable the bystander effect. That means the drug, when they do internalization, they will release the payloads to the microenvironment. It's stable in plasma and designed to be cleaved by lysosomal enzyme overexpressed in tumor cells, and drug to antibody ratio of 7.8. As HER2 targeted option continue to expand, physician will weigh many factors when sequencing treatment. More than 1/3 of the patient will not receive subsequent therapy after second line of treatment, and these are it depends on the performance status. They miss an opportunity to receive a highly effective HER2 targeted agent if not prioritized for early use. And the first line, in this slide, you can see the sequencing, the treatment, and as we can lose a patient, and some patients cannot benefit from the line. It depends on the performance status. However, the trastuzumab deruxtecan versus trastuzumab exemestane in patients with HER2 positive metastatic breast cancer, it's an update result of the randomized phase 3 trial Destiny 3 that was presented in San Antonio in 2022. So the background, it is the approved treatment of HER2 positive metastatic breast cancer is the famous Cleopatra trial with trastuzumab, pertuzumab, and taxane as the first line is a standard of care established in Cleopatra trial. And the second line, the TDM1 Emilia trial with a median PFS about 9.6 months. The TDXD in HER2 positive metastatic cancer based on the strength of breast Destiny breast 3 efficacy and safety data, TDXD is considered preferred second line treatment and TDM1 as an alternative option. An update overall survival data of Destiny breast 03 randomized open label multicentric study. The criteria of inclusion were patient unresectable metastatic HER2 positive breast cancer, previously treated with trastuzumab, taxane, or in metastatic or neoadjuvant setting with recurrence within 6 months of therapy. The randomization is done between the TDXD versus the TDM1, and the primary endpoint is the PFS, and a key secondary endpoint is the OS parameter. Okay, what about the patient disposition? The patient disposition, it's a patient randomized but not treated. There is about a small number, and the median study of the follow-up about 28.4 months range, and in the TDXD arm. However, in the TDM1 arm, about 26.5 months. What are the characteristics, the baseline characteristics of these patients? Mainly, most of the patients were Asian population, about 60%. However, European, were 20%, and the rest of the world, about 15%. What about the HER2 status? The HER2 positive, about 90%. HER2 plus 2, it's about 10%, and plus 1 is not evaluated, is about 1%. All of them are good performance status with hormone receptor positive in 50%, and baseline brain metastases were allowed, and it was about 16%. There's a history of visceral disease in 70% in TDXD arm. The prior therapy, so any prior systemic therapy like trastuzumab, pertuzumab, or anti-HER2 were included in this trial. The number of line on prior therapy in the metastatic setting, the average was 2, and some of them were heavily pretreated, reaches more than 5 lines in 12% of the patients. The updated primary endpoint, the PFS, we see beautiful separation of the two curves, and the TDX in favor of the TDXC, about 29 months of the median, with a hazard ratio of 0.33 and a significant p-value. The PFS by the investigator, we show a beautiful, clinically and statistically significant separation in favor of the TDXT, about 30 months versus 7.2 months for TDM1, with a hazard ratio of 0.3 and a significant p-value. The secondary endpoint is overall survival, and again, it is positive, and it's in favor of the TDXT with a hazard ratio of 0.6, and the p-value is also significant. The overall survival in subgroup, in the subgroup analysis, you can see in the forest plots, all were in favor of the TDXT. It was conferred by objective response rate and other efficacy endpoints. The PFS and post-study anti-cancer treatment, as we can see here, most of the patients received multiple lines of therapy, especially the anti-HER2 treatment. The overall safety summary, the median treatment duration was 18 months, and for the TDXD, however, for the TDM1 was about 7 months. The most common side effect was more than 20% of the patient in TDXD. It was of any grade, it was more than anemia, it was 9%. The most common is the neutrophil count is the decrease about 16%. And what's causing problem with this drug is the drug-related interstitial lung disease pneumonitis. It's of different grades, ranges from grade 1 to grade 5. According to the trial, this side effect, it occurs lately after the initiation of treatment. The drug-related interstitial lung disease pneumonitis rate were similar to other metastatic breast cancer with TDXD. With longer treatment exposure and follow-up, the ILD pneumonitis R rate increased from 10% in the PFS interim analysis to 15%. There are 4 additional grade 1 to 8 additional grade 2, no additional grade 3 event. The overall incidence of grade 3 event was 0.8, was same as in the PFS interim analysis. There was no drug-related grade 4 or 5 event. In conclusion, TDXD demonstrate clinically meaningful and statistically significant improvement in overall survival over TDM1, as well as continued PFS benefit in patients previously treated with trastuzumab and taxane. These data are consistent. Overall survival benefit was observed across key pre-specified subgroups with a longer treatment duration. TDXD continues to demonstrate a manageable and tolerable safety profile. With that, I thank you for listening.
Thank you very much, Sadad. I think for the sake of the time, we need to move to the second presentation or satellite symposium. It's my pleasure to invite Dr. Ahmed Badib. He's a consultant medical oncologist at King Khalid Hospital in Najran. He's a senior medical oncologist and he will chair the next session.
Thank you, Dr. Mohammed, for the kind introduction, and thank you for the invitation. And it is really a pleasure to be with Dr. Ahmed Al-Ubari. Dr. Ahmed Al-Ubari is beyond any introduction. He is a consultant medical oncologist at King Fahd Specialist Hospital, Dammam, and he is a leader in breast oncology group. He is also clinical assistant professor at Arkansas University for Medical Science. He will teach us regarding the adjuvant CDK4/6 inhibitors in breast cancer. Welcome, Dr. Ahmed.
Assalamu alaikum, shukran, Dr. Ahmed. Thank you very much for the introduction, and thanks, Lily, for the opportunity to talk about the adjuvant CDK4/6 inhibitors in breast cancer. So the talk, so this is my disclosure, and the outline of the talk today will be simply a background, followed by the trials and evidence pertinent to adjuvant CDK4/6 inhibitors, and then conclusion. So from early on, really, we recognize that the choice of chemotherapy improves the disease-free survival. For instance, AC followed by docetaxel was superior to AT followed by capecitabine. That was proven to be right in disease-free survival, but overall survival was non-significant. Then later on, and these are really very old trials that showed the FIC with docetaxel has improved disease-free survival, distant disease-free survival, and overall survival over FIC alone. So it really established the choice of chemotherapy and the kind of chemotherapy that you want to administer to the patient to improve their outcome. Royal Marsden have shown in their trial that tamoxifen is an effective treatment for adjuvant ER-positive breast cancer. Then later on, the extended treatment with AI, especially for the premenopausal women with ovarian suppression, have shown an improvement in reducing the recurrence in these patients. And chemotherapy, later on, the role of chemotherapy has really evolved around the genomic platforms and whether to use adjuvant chemotherapy in these patients will be dependent on the recurrence score. So we try to define patients' risk and categorize patient risk so we can add or subtract treatment according to the risk. It's kind of tailor the treatment to the needs of the patient. So one of the features that we just mentioned is the genomic features by Oncotype DX or Monofrent and other agent or other tests. And simply the definition is high risk more than 25 in Oncotype DX, and then there is a subgroup of intermediate risk and low risk, depending really on the patient's age and clinical features that we will not do. But generally, Oncotype DX or genomic expression is important in defining patient biological risk stratification. The other feature is the proliferation index. One of the most famous proliferation index is the Ki-67. And again, the problem with Ki-67 is how do we define the risk based on the cutoff? So where do we draw the line? And then the other thing is reproducibility of Ki-67. And I think that later, especially for Ki-67 more than 30%, it seems like the reproducibility is much easier between different pathologists. And now we have even more automated Ki-67 with integration of AI or artificial intelligence. And in the future, the Ki-67 will be more accurate. CDK4/6 agents that we have in the markets, ribociclib, palbociclib, and ribociclib, are the three agents that are approved and commonly used in the market. And all of them showed they met the primary endpoint in their trials, which is progression-free survival, certainly in the first line, similar performance in the first line, and similar hazard ratio. But palbociclib really failed to show an improvement of overall survival in their trial. All of their trials came to be negative for overall survival, while MONALEESA, which is ribociclib, showed overall survival in their own program, MONALEESA program. And finally, the MONARCH 2 showed overall survival benefit with combination. It's a second line combination with fulvestrant, and we still wait for the maturity of MONARCH 3. So let's move on to the adjuvant setting. So the first trial that we will talk about is the PALLAS trial. So it's randomized phase 3 that enrolled patients with different risk groups, stage 2 to 3, hormone positive, HER2 negative, large number of patients, 5,760, were randomized to receive palbociclib for 2 years with AI compared to the standard of care AI. And the primary endpoint here is invasive disease-free survival. And one of the secondary endpoint is quality of life adherence and patient-reported outcome. Now, it's worth noting that around 20% of patients were below T2, so T1, T0, and around 12% of patients were node negative. And then when you go through the other stratification of patient characteristics, you see that the majority of patients were grade 2, and around 1/3 of patients were grade 3, so grade 1 was minority. The problem with this trial is that early discontinuation, around 42.2% of patients discontinue the treatment because of various reasons here. Majority were due to adverse event, and they were deemed to be unacceptable toxicity, and around 5% of patients were just non-adherent to the treatment. So it was really a problem with the PALLAS trial. Nonetheless, invasive disease-free survival was negative. You see complete overlapping of both Kaplan-Meier curves and hazard ratio 0.93. And in distant recurrence-free survival, same story, and the hazard ratio is actually 1. So there isn't really something that stands out from the first plot. Both they crossed easily the hazard ratio line. And one of the reasons why we thought that this has happened is because of the discontinuation rate. But then when the investigators looked by what's called dose intensity, meaning patients who have received palbociclib, more than 70% of the dose of palbociclib administered, they did not show any difference. So really, palbociclib in the PALLAS came to be negative. So 2 years of palbociclib in unselected risk with residual invasive disease has no benefit in adjuvant. Now, the investigators then thought that let's redefine our patient's risk and then apply the same story, but here with high risk. So Penelope B, again, phase 3, but patients with no PCR after neoadjuvant treatment with high grade 2 or 3 and node positive, 1,250 patients were randomized to receive palbo and AI versus AI, but this time it's for 1 year. And again, the same endpoint, which is invasive disease-free survival. And it was promising really in the beginning, so there was separation of the curve, but then with further follow-up, the curves met again, and the endpoint was negative. So the p-value was 0.5. And when you look at the first plot, once again, you see that there isn't really something that you can utilize from the first plot. And overall survival, which is secondary endpoint, showed, again, no benefit of adding 1 year of palbociclib in high-risk group, per the definition of this trial. How about monarch-E? So we know from early on that the monarch-E was positive when the abemaciclib was added to AI with the primary or the first analysis at 15 months. There is an improvement in invasive disease-free survival and distant recurrence-free survival. But this time we will talk about the 27 months, because remember that the Penelope was positive in the beginning and failed at the end. So as oncologists, to be honest with you, we were also kind of apprehensive about the fact that, oh, is monarch-E going to fail again in the longer follow-up? And also the role of Ki-67 in defining risk, and whether the Ki-67 is an important factor, because again, let's remember that the approval in the United States was for patients with high Ki-67. So patients criteria, men or women, pre or post-menopause, and that's important in my opinion. Those with adjuvant chemotherapy, neoadjuvant chemotherapy, or no chemotherapy at all, which is again an important point. And obviously they have no metastatic disease. And the last point that I think is essential is they included patients who have had the treatment finished, the adjuvant or neoadjuvant treatment finished, or definitive treatment finished, and they are on endocrine therapy for 16 months before enrolled in the trial. So oftentimes you see patients as a second opinion who have been treated by other physicians who did not think of abemaciclib as an agent that they will use for various reasons, availability, or they just didn't think about it. And then they come to you after 8 months or 6 months, they still are eligible per the criteria of this clinical trial. So we'll focus on cohort 1, which is the primary, which is the patient with high risk clinical pathological features, 4 or more lymph nodes, or 1 to 3 lymph nodes with at least grade 3 or T3. So those patients were randomized to receive 2 years of abemaciclib twice daily, the 150, with standard of care endocrine therapy versus endocrine therapy alone. And the primary endpoint here is invasive disease-free survival, and secondary endpoint is invasive disease-free survival in high Ki-67 population, distant relapse-free survival, overall survival, safety, pharmacokinetics, and patient-reported outcomes. And as we can see that the groups were balanced in terms of characteristics between 2 groups, and balance in the group itself, because it's important to know that 43% of patients were premenopausal females. And then the patients, the median age was 51. Remember that in the West, majority of patients who the age of incidence, for instance, in the United States is 61. So this is kind of balanced out the patient characteristics. Majority had T2, by the way, and around 40% had N1 and 60% N2. And majority, again, had grade 2 or grade 3. Only 7% had grade 1. Now, as far as Ki-67 goes, 1/3 of patients had low Ki-67 or less than 20 Ki-67. And 44% or 45% were Ki-67 more than 20%, and around 20% of patients or 21% of patients had unavailable Ki-67. And I think this is also important because we'll see later on what's the importance of Ki-67 in this trial. And at the follow-up on April 2021, 90%, almost 90%, 89.6% were off the study treatment. So the level of maturity is very high, and completed 2 years of treatment around 72.2%. So let's talk about the efficacy results here. So we know early on that the result was positive, but this time it's 27 months and 36 months, 27 months result showed a continuous improvement in the invasive disease-free survival. We were very happy to see that. That translated to a 30% reduction in developing invasive disease-free survival at 5 years. At 3 years, sorry, a more than 5% improvement in invasive disease-free survival. The whole idea here is that we did not see what we saw in Penelope, where the Kaplan-Meier curves met down the road. Here, the separation is even higher, suggesting that the separation on longer follow-up or the benefit on longer follow-up will be higher. And hazard ratio has improved from 0.73, I think, to 0.69, which is really reassuring in terms of invasive disease-free survival. I don't see any subgroup that does not benefit from abemaciclib. I want to highlight one group of patients that we tend to shy away from advising them or recommending adjuvant abemaciclib, which is the elderly population. When you look at here, patients with more than 65 years old also benefited from the adjuvant abemaciclib. So that tells me that, you know, with appropriate follow-up for older population, we still can recommend it for these patients if they fall into the category of high risk for recurrence. Distant relapse-free survival has also shown similar pattern of improvement, a 31% reduction in distant recurrence-free survival, and that is again an important endpoint that we look at in trials like this. When you offer patients a treatment that has a risk, what is it going to help the patient in terms of distant recurrence-free survival? Because local recurrence is one story, but distant recurrence is even harder to treat and may result in worsening survival. So here is an improvement of 4.2 in distant recurrence-free survival. So again, this is this table is just to show you that there is a continuum of improvement in hazard ratio in invasive disease-free survival as well as distant recurrence-free survival. Now let's talk about Ki67 subgroup. We remember that the Americans, they approved this medication with a precondition that the Ki67 should be 20% or higher. And it certainly for intention to treat analysis, all group, the Ki67, if it's higher, there is a worse outcome as in general. But the invasive disease-free survival did not go down for these patients. In fact, there is 33% reduction in invasive disease-free survival. The absolute benefit is 6%. And when you look by the cohort 1, which is the one that we will discuss today, 37% reduction in invasive disease-free survival. Absolute benefit is 7.1 in those patients with high Ki67 and cohort 1. What's interesting, in my opinion, is this slide. Irrespective of the Ki67, the benefit is maintained. We know that Ki67 is high, has worse outcome, but it does not really predict the response to abemaciclib. In other words, it is a prognostic for worse outcome when you have higher Ki67, but it does not predict the benefit of abemaciclib, adjuvant abemaciclib, and in fact, it doesn't have the result is consistent or the benefit is consistent regardless of the Ki67. Finally, is the safety report. We're very familiar with abemaciclib now. I think all of us have patients treated with abemaciclib in the at least in the metastatic setting. Diarrhea is the most common, as you know, but the most common grade 3 is neutropenia. And both of these side effects are easily managed, in my opinion, with diarrhea, with dietary modification, loperamide, neutropenia. We're very familiar with neutropenia associated with CDK4/6 inhibitor. The two other interesting side effects are VTE and interstitial lung disease. They're not very common, 2.5 VTEs in general, and ILD is 3.2. But when you treat larger number of patients, you expect to see more patients down the road. So it's just an advice to us to really pay attention to side effects and anticipate PEs, anticipate ILD and cough and shortness of breath and stuff like that. So close monitoring for these patients is recommended. So in conclusion, really, abemaciclib has shown a continuous improvement in the primary endpoint that we know from the first analysis, invasive disease-free survival, the distance relapse-free survival, beyond 2 years, which is extremely reassuring. And not only that, the benefit has improved over time, the hazard ratio has improved over time and longer follow-up. And the safety data with high level of maturity didn't really show anything unusual or that we don't know about abemaciclib. And the Ki67, though it's a prognostic index, was not predictive of response to abemaciclib, and the results or the benefit of abemaciclib was consistent in high Ki67 and low Ki67. And then obviously we'll follow up for overall survival, and it became really abemaciclib one of the options for patients, especially for those in the adjuvant setting who have no germline BRCA mutation with high risk of residual disease. They became standard of care. The NATALEE is the ribociclib trial. It's still not mature yet, and we don't have any data from adjuvant ribociclib. And finally, we'll talk quickly about the meta-analysis. there was a meta-analysis that just put it there. There is a trend to improvement in invasive disease-free survival. The benefit is mainly driven from the Monarch E. So you see some of the patients, subgroup have crossed the hazard ratio line in this meta-analysis, as well as distance-free relapse. Is clearly the benefit was driven from Monarch E, and it just did not have any new sort of recommendations, because we know what it is. Quickly on the comparative view between the three trials, Monarch E is abemaciclib for high risk for 2 years. Discontinuation rate is low. PALLAS on 3-year follow-up, negative invasive disease-free survival and distant recurrence-free survival. One of the reasons was a discontinuation rate, which is high, and then Penelope B is negative invasive disease-free survival and distant recurrence-free survival, high discontinuation rate, and it's thought to be also related to this 1-year treatment instead of 2-year treatment. So it's kind of story is complicated with the palbociclib in the adjuvant setting. So the question is why there is difference in outcome. We explained some of these differences. I think, in my opinion, that these agents are different and they produce different results. Simply, there is a different IC50 to different enzymes, including CDK2, CDK7, and I think abemaciclib is a potent CDK2 inhibitor, which has a role in pathogenesis of breast cancer. So the bottom line that we're not going to go through the PALLAS and Penelope B again, but we know that they are negative. The Monarch E has established abemaciclib as a new standard of care with reasonable discontinuation rate, meaning reasonable tolerance and toxicity, and it became really something that we use in the clinic. And disclaimer here that I do have patients already on adjuvant abemaciclib, and I'm sure that you guys have too. With that, I'd like to stop here. Thank you for listening, and I'm ready to take questions. Thank you very much.
Thank you, Dr. Ahmed, for this comprehensive talk. Now for questions, do you have any questions from the floor or? Okay, I have a question, Dr. Ahmed. Now with this approval of abemaciclib from Saudi FDA last month, as in the early breast cancer as adjuvant, the options are, we have much options now, and we are facing some difficulties. I have one patient, hormone positive, operated with residual disease, and she is also BRCA positive. So how can I sequence my therapy with the Olympia A, with Monarch E, and also with CreateX? We have how can I choose? How can I sequence my therapy?
Recently, we had a discussion. I think this is Dr. Ahmed is a data-free zone. Really comes down to two things, in my opinion. One is patient characteristics in terms of age, tolerance to treatment, agreeable, or that the patient is agreeable to have extended treatment or not. And then from the patient characteristics, also the tumor characteristics, which is kind of falls into that category, whether, T1 is not T4 in the beginning. If the patient had chemotherapy versus no chemotherapy, all of these will play a role in how to decide whether to give all the treatment or to give part of the treatment. And in my opinion, the other part is the physician. The physician also role or related, which is experience with PARP inhibitor, experience with abemaciclib. Finally, in my opinion, if the patient has BRCA, we do have an outcome that showed improvement in overall survival in the Olympia. So that's clear to me that adjuvant olaparib is the way to go if you have germline BRCA. But if it's wild type, then the options are the option is abemaciclib. Remember that the Xeloda in ER positive, the result was not very great. So I wouldn't use capecitabine for patients with a residual disease when they are ER positive. In fact, I have not been using it for the last few years, even if they have in one disease. Capecitabine benefit in Kyriatic X was driven by triple negative and not by ER positive. So abemaciclib in germline negative, BRCA negative, and Olympia or olaparib in germline positive. If they have, if you want to use both, I think you should start with olaparib and then go with abemaciclib. But it would be very hard. 3 years of adjuvant treatment with these may be a challenge. I haven't had a patient who faced this questions yet.
Thank you very much, Dr. Ahmed. It was very comprehensive talk, and thank you, Dr. Nafisa, Dr. Muhammad, for this opportunity. Thank you very much.
Thank you. Assalamu alaikum.
Okay, thank you very much. I think today we have come to the end. I would like to thank our eminent speakers and moderator, our physical and virtual attendees, and our sponsor as well. And hopefully to see you tomorrow, inshallah, at 9 a.m. Assalamu alaikum.
السلام عليكم. السلام عليكم. Assalamu alaikum. Thank you for being here today. To get your CMEs, you have to attend the 2 full days. So we'll be happy to see you tomorrow. We will be starting at 9 a.m. So see you then. شكرا جزيلا لحضوركم اليوم الأول من المؤتمر. للحصول على الساعات المعتمدة يرجى العلم بأنه عليكم حضور يومين متتاليين، وسنسر جدا برؤيتكم غدا صباحا الساعة 9. شكرا لكم. جمعة مباركة.